Good morning, everyone. It's a pleasure to invite you all for this in-person meeting of the CSI Mumbai Branch. As we are aware that since the last two years, nearly, or 1.5 years, we've been regularly having our meetings thanks to the very enthusiastic initiatives by Dr. G.R. Kane and Dr. Milind Phadke and all the other committee members. Today's topic is on complications of percutaneous coronary interventions, and I think it will be apt to start on time. It's really heartening to see so many people come on time here. So without wasting time, I'll invite Dr. Kane to say a few lines, and then we can start the academic program. Thank you.
Thanks, Bhavesh, and good morning, everybody. So this is a session which is of interest to all cardiologists, and more so to obviously people who do interventions. So we have a packed program, so we'll have to try and stick by time so that we can give chance to everybody, and we have a general body meeting also after that, which is supposed to be held every year. So let's discuss, debate, and try and learn from each other. Thank you. Let's start. Yeah.
The coordinators for this program are Dr. Samir Pagar, Dr. Amit Sanghvi, Nihar Mehta, and Milind Phadke. There is a little change in some of the case presentations because of somebody is not yet reached. You understand? Dr. Brajesh has requested that he wants to go early, so we'll start with his case. So can we have Brajesh? Can you please come? And can I hand over the proceedings to the coordinator so they can take it further?
And now the first presenter is Dr. Brajesh Kumar. He is going to present the complication that is lost in anatomy, anomalous RCA with thrombus migration. Dr. Brajesh, please.
So good morning, everyone. So this patient was a very VVIP patient. He was a Joint Commissioner of Police, was shifted to our center with cardiogenic shock and complete heart block. And ECG was showing inferior wall MI. So as usual, we gave an atropine, started him on inotropes and took him IV fluids and took him to the cath lab. And the left side was non-contributory. It was okay. I mean, hardly anything, minor diseases. This was the ECG was showing inferior wall MI with RVMI. So this was the shoot of right coronary artery. I mean, after putting a temporary pacemaker, we realized what exactly is happening. I mean, what is this course of this? This is a aleocranial view. Next. So this was seems to be a coronary artery, right coronary artery, but see the size of the coronary artery. It was almost like 6 to 8 mm. And the course was a bit abnormal. It was going posteriorly behind the aorta. So in both the views, we could not find what to happen, I mean, what to do next. So we wired it, we did a thrombosuction, but wire was going somewhere else. I mean, if you see the wire, there was a lot of thrombus because of the ectatic.
Can you show the first view? Sorry, go back to the first view. Yeah, play. There's some distal flow here, you see something.
Yeah, so we thought we will wire it, let's do a thrombosuction and see what is happening. And in between, the patient has runs of non-sustained, sustained VT, VF, was getting shocked as well, and intermittently was going into complete heart block. So we were able to manage this patient without intubation. And then there was a time when we thought, now we are not reaching anywhere. What we did is we gave an intra-arterial tenecteplase, 15 mg, because the wire was not going anywhere. We thought the thrombus load is much, and we wanted to know what exactly is happening. So post giving a tenecteplase 15 mg, we waited for 5-10 minutes, and this shoot showed there was a nipple-like thing there in this fistula. Next. And then we wired that nipple, and that was the RCA which was arising. Next. Now we took a 2.5 mm balloon and dilated this, and this was the flow started from that fistula. And immediately after this, patient suddenly had an arrest, VT-VF, we shocked it, and we realized, next, that the whole of the thrombus in the fistula has gone into the distal RC again, and the flow has gone down, and patient has a totally occluded RCA once again with the thrombus going distally. So this was probably because of the large thrombus which was there in the proximal RCA going into the distal. So we have to do CPR, we have to shock him, and then took a thrombosuction catheter, sucked the clot. We thought of taking a distal protection device here, but with this type of scenario, which size of distal protection device will go? I mean, we hardly had, 6-7 French will not go into this. The vessel was looking like a 3.5 mm. So we just continue to give him, since we have already given intra-arterial, intracoronary tenecteplase, we were little reluctant in giving tarabifan also. Suppose our wire has gone somewhere, start, causing tamponade. So we decided anyway we have to give him, we have to open that vessel, and we put a stent across it. Now from where to put a stent, because there was a lot of disparity between the RCA, the real RCA and the fistula. So I thought that let us stent it from the ostium, from where the RCA is arising. It was a fibrotic this thing. Initially I thought let's do a POBA and leave it. But it was getting recoiled again and again. In spite of dilating with a 3.5 mm NC balloon, it was recoiling. So I decided let me stent it. Probably that will keep and the moment the RCA stops flowing, the patient used to get CHB or VT-VF, one of them. So this was the final result. We got over the case, and within no time the patient came off inotropic support, hemodynamically got stable, and was discharged in 2-3 days. Now, this patient, to know what is happening later on, probably 3 to 6 months down the line, he got a CT angiogram done and found that this was the reported CT angiogram. CT coronary angiogram showed markedly dilated and tortuous proximal RCA 6.6 mm, bifurcating at mid-segment into large acute marginal branch, fistula proper, and a small distal RCA. Terminal fistula segment largely thrombosed with mass effects on SVC. Prior PCI stent visible with no instant restenosis. This was 3 months down the line. Now, we did give an option of patient for a surgical, and right now the patient, 6 months are over, the patient is on single antiplatelet and NOAC. We have given them an option of getting a surgery also done, because this can get repeated. So, but he's very fit, he's running around, he's a joint commissioner of police. So this was something which probably I thought the timely intracoronary lysis has helped us, otherwise we were in soup. It was, if you see the first angiogram, there was no hint of where this RCA is arising. There was no nipple. I mean, we kept on searching where is the RCA, and we kept on doing a thrombosuction of that fistula, which was not useful. So that intra-arterial thrombolysis helped us, and the migration of thrombus from that large anomalous fistula into the RCA again created a complication. So. And Dr. Keval was with me in this case. He's my DNB second year student.
Just one question. Do you think there was a primary issue with the RCA arising from the fistula, or was it primarily a thrombus in that large fistula which was the etiology?
So both the things were there. If you see the left side coronary also, it was not like a completely normal coronaries. There were atherosclerotic changes in the LAD and circ. And even the lesion in the RCA ostium, it was tight stenosis. It was not only thrombotic occlusion, it was a tight stenosis. We have to go at high pressures to crack it. So he had an underlying atherosclerosis. On top of that, this fistula is created. I mean, the atherosclerosis on top of fistula has created this. I think the only problem in a routine cases, you can get away easily, but the thrombus load because of that fistula created more issues.
That was a nice case. I mean, I think all of us would have been stumped by what we saw. But I think what is the dose of intracoronary tenectoplase that is suggested? What is the exact dose that it should be given? Is there a protocol?
Some people say 1/4 of the systemic doses. We gave it 15 mg. We thought that, and even I was thinking to repeat it if it doesn't work because the thrombus load was huge. I mean, I had no other options. I need to see something arising from the RCA. I mean, you see the course of RCA, it was totally going back. That fistula was going back. I'm not reaching anywhere. So 15 mgs, I thought I'll give it. And many of the guidelines have said 15 mg is a good dose to. Probably we just showed the paper.
So one of the takeaways from this is that use intracoronary thrombolytics whenever you feel that the thrombus load is large, because the RCA is one artery which is very unforgiving.
Absolutely, sir.
Most of the RCAs are the ones that you land up in trouble if there is a distal embolization. The other thing that probably you did what was best in those circumstances. Just a thought crossed our mind that in such situations, is there a role of using a distal protection device in the distal vessel before we handle the, once you got the flow, put a distal protection device there because you know the thrombus load is large.
I agree, sir. I said that distal protection device, I thought of using it. Vessel size initially was appearing like a 2.5. Only when I dilated became 3.5. So which distal protection device? I mean, usually the cath lab distal protection device which we have right now is something like a spider, which is I usually use it for carotid. But that is 7 mm, 6 mm, 8 mm. The size disparity was huge. So, and then there was another thing which was which was there in my mind. The more I was handling the proximal RCA fistula, more I am pushing the clot inside.
Absolutely, that's going to happen because that is the way the thrombus migrates.
Yeah. So distal protection device in 3 mm vessel, I was thinking it will create more of a mess rather than, and I don't have that on table. I mean, I don't know whether it is available or not. 3 mm. 3.5 mm.
You get a 3.5 to 4.5 distal protection device.
Yeah.
Which
so
is
if you see the first shoot after dilatation, the vessel was not looking big. I was thinking, is it a branch of RCA or there may be another RCA? But once it opened and I made it 3.5 mm stent, then it was looking little big. So of course, the distal protection device accepted, sir, would have been a better choice. IABP for inferior MI. I thought my aim was initially to sort out the obstruction. You know, he was not giving us chances. So right coronary artery, I have not been using IABP. Usually it is the. Yeah. So we were giving fluid. We were giving a lot of fluids, inotropes. Right coronary artery with CHB. My aim was, it was a Sunday, 11 o'clock. My aim was probably to open the vessel first. And if it doesn't improve, maybe put an IABP along with that. But right coronary artery, I thought the hypertension it was an acute event. I thought once I get away the block and get a good TIMI3 flow, I may not require an IABP. And also if you see the recent guidelines, IABP has no role nowadays, you know. So IABP, our use in our cath lab has really come down after this guidelines.
No,
of course.
Having said that, whatever the guidelines in IABP are, in terms of the use, we don't have, they're comparing IABP to other devices like your Impella and other devices. For us, in the absence of the Impella in every lab, I think IABP still has a role to play.
But sir, in inferior MI, like this, will you
fair
use
enough.
an IABP?
It is conditional. It is conditional.
Yes.
Yeah.
Inferior
Any
MI
suggestions from the audience? Any other way that anyone would have done it?
Can I make a comment? Brijesh, intracoronary tenectoplase 1/5 the dose, not 15 and all. That's
So,
one thing. I'm just saying,
yeah.
for him.
So 10 mg we thought of
I'm
because
just
his
saying,
weight was
I'm just saying my comment. And the remaining tenectoplase you give intravenously.
intravenously.
You have given that or you have through that?
No, we sorted it out on the table itself, na sir.
No.
Our aim of giving an intra-arterial intra-coronary lysis was achieved. Once we gave an intra-arterial thrombolysis, we could achieve a good, we could see a nipple, and we did a good revascularization. Now giving a systemic thrombolysis on top of that, I thought it is not needed.
See, recommendation, whatever you say, whatever.
After stenting, I mean, now I'm giving ticagrelol, all those things also.
And therefore, here again, why we should, give aspirin, clopidogrel before any procedure. And when you do the angiogram, you can again upload ticagrelor. If you already given ticagrelor, giving again, your thrombolytic will be an issue in here. So the recommendation, like Dr. Jayagopal, he is one of our, he has got a large study, 1/5 do give intracoronary, remaining give 4/5 intravenous, and then heparin and all. At least personally, I would have given more of a lytic and medical therapy.
So in this case, I would have done that if I would not have did a angioplasty or stenting. Once I did a stenting, I thought there's no point of giving an IV infusion. So my aim in this was, I achieved my aim by getting a good TIMI3 flow in the end. So I was thinking giving him with so much of CPR going on, shocks has been going on. And then I may need a revascular IABP also if it doesn't improve. All those thoughts were there in my mind. The moment I got a good TIMI3 flow, I waited for some time, 20 minutes, for still waiting for a thrombus migration, any further thrombus migration happens. Once I saw that the inotropes are going down on table itself, patient starts improving on table itself, I thought giving an infusion will be a problem.
Right. Thank you so much,
Sure.
Brajesh. I mean, that is a very well thought out case. Excellent result.
Dr. Brajesh, you are not aware that I was involved before you because he is my constant, his family is my patient, and incidentally he just called me right now for other reason. So he was in trouble, he was in traveling, he called me what to do. I said go to the nearest. Then he took your name and said he is the best, he can do all complex cases. Went there, after that he came, actually second the CT angio was advised by me, and that also I think is now 4, 5, 6 months has passed now.
Yes, sir, yes.
And he is fine because just now, half an hour back he called me for some other reason. Wonderful case, I think, is wonderfully done. Thank you very much.
Thank you.
All right. Let's go on to the next topic, Dr. Reddy, on when the stent strikes back, stent thrombosis.
Good morning to everybody. I think my case is more or less same right coronary artery and thrombosis related. This case was done in 2020 at Jagjeevan Ram Hospital when I was working. He's a 51-year-old male. As a known case of seminoma testicles, was taking chemotherapy. And prior to admission to our hospital, he received 3 cycles of chemotherapy. We don't know what was the chemotherapy was given. He was not aware of that. He is hypertensive, diabetic, and hypothyroidism. 3 days later, after the cycles of chemotherapy, he was admitted to Jagjeevan Ram Hospital with the chest discomfort and palpitations, and ECG showed atrial fibrillation with the ST segment elevation, not classical. You can see the inferior leads, there is an ST segment elevation, and AF with a past ventricular rate. Routine investigations were normal, even including creatinine, and we thought immediately we'll take him for an angiography and loaded with dual antiplatelet drugs. And this is an angio done through the right radial route. You can see the left system was normal. On the right coronary artery shows proximal there is a thrombus. Probably it is a ruptured plaque, looks like.
So one of the things before starts that, the previous case, the real benefit to you, Brijesh, according to me, was, can somebody give me a mic, that the artery which you stented was of normal size. So otherwise, if the whole artery is ectatic, which is a normal thing that we face, because this is a very rare thing, so should we stent those arteries? I normally don't stent if there is too much of ectasia and thrombus. You give thrombolysis, then continue either tirofiban also or heparin or whatever. Yeah, come on. Yeah. Till he gets that, we can discuss. Milind. Exactly. Yeah. So the rest of the artery was of normal size.
That was a normal.
So that's why you could stent it that easily, and it worked very well.
Kane's question is, if you have a large ectatic right coronary artery full of thrombus, should you stent or not?
Yeah,
I think most of us will not stent such a patient. Even I'm going to preempt Reddy's case and say that large amount of he showed it ran for one time.
Okay.
So I'm going to preempt. Actually, I should not. Let's not.
Yeah, no.
But Dr. Reddy's case is rupture plaque or is a coronary thromboembolism?
So that's why I did not want to preempt this case.
So just one thought process. Patient is doing well and everything is fine, but the CT reported that there is some mass effect on the SVC. So should that fistula be left alone or should it be treated?
Absolutely asymptomatic. Echo is absolutely normal. And if you also see the CT report, it's already thrombosed. The fistula is already thrombosed. It is not draining anywhere. And I'm sure by over a period of time, if the patient gets another CT, you will find it further getting it atretic. There is a possibility. But yes, we have given a patient an option that since we are not sure about what is next, suppose you can have another thrombus going into a native coronary, you can go for a minimal invasive CABG where just a small incision and given RCA graft and clamp the fistula completely forever. This advice, I think many of the doctors have already given him. So I spoke to him a month back, someone from family called me and they say he's doing very well, so why should we go for a surgery? So that is what I told him, that I will like you to be on Novak and a single antiplatelet and of course a statins. So it's already thrombosed. The distal part of the fistula is not seen. But still there's a danger of repeating this event. This time the stenotic part is sorted out. I mean, this patient did not have only thrombotic part. He also has a tight stenosis. So that was the reason why I stented it. And repeatedly balloon dilatation, it was getting, re-occluded. Mass effect, probably the organized thrombus is not getting, normally if there's a blood in the vessel, it can, squeeze out. But once the thrombus get organized, probably it is forming a thick cord-like thing.
Chalo, Dr. Reddy, I think we are on.
When we are at this topic, since Tilly puts it up, how many of us still use intracoronary thrombus aspiration as a routine in acute infarcts?
Not routine. Define routine. Define routine.
Large thrombus burden.
In fact, I believe that I have used many times after putting the stent when you have no inflow or slow flow, because the thrombus get messed up and it blocks everything. If you do a thrombus suction, that time also you have a better result. That's what I believe.
I think that's when you use a thrombus suction catheter post stent deployment and you have no flow. That's basically for getting drugs into the distal circulation. Yeah.
I think, sir, I'm doing a lot of PAMIs. So the evidence that in our thrombostat device, you get a lot of clots, that itself suggests that we are doing something to the clot. I mean, if you do a thrombosuction and you get a big chunk of clot, I mean, you tell me what other way with the clots can be sorted out. I mean, either you are going to push it distally or you are going to squeeze it against the wall.
Yeah.
So I feel once you get a thrombus in the thrombostat, that means doing a wonderful job.
Our question was routine. That means for everybody that you see a thrombus. So point is in your particular case, one of the things, so your thrombus for that big thrombus is too small. One of the things that could have been done, one of the things you could have done is jam your entire guiding catheter and try to aspirate. You get big chunks. So you would have probably got a large, okay, he's on to it. So they are ready, yeah. Dr. Reddy is ready now.
So initially we thought it is approximately a right coronary artery is in a rupture.
So can you just for a moment, since Ajit raised this issue, so for this, Ajit, are you saying for this case you would have liked to do a thrombosuction? Is this what you mean by routine? Yeah. So this is okay. Let's for a second pause. A show of hands for this case. Brijesh, for this case, how many would do a thrombosuction? I wouldn't.
I would do, sir. Once you have a TIMI3 flow, there is no point of.
No, I shall rationalize this a little bit, because the only reason I would use a thrombus, it's a huge RCA. In an RCA, if a thrombus goes distally, even the TIMI3 flow will go down to TIMI0. So I mean, as long as you are wedged into the right coronary artery, you do not have any part of the of your guiding catheter floating around. You can, I think, it's worthwhile. Whatever the studies show.
Keep the guiding inside so that you don't have an embolization.
Why wouldn't you do it? Because it's been shown to have increased complications. So the word the routine, see, Samir, correct. That's why he used the word routine.
There is a risk of embolization even with thrumbustor.
Now we asking. So I wouldn't do
There is
this.
a risk of embolization even with thrumbustor.
Irrespective.
So
Dr. Reddy, I'm going to just point out to you in this case. So I'm sorry, I introduced this thing. I'm going to point out to you that the thrombus seems to be layering 2/3 of the entire coronary artery in this particular case.
Yes.
Correct.
Yes. So we thought initially we'll do the thrombosection, whatever the benefit we'll get. Even if you minimize the thrombus burden, I think it will be better before deploying the stent. And we decided in this case, go for a direct stenting. It's okay, direct stenting in this case or requires to be post-dilated?
Now finish the presentation, sir.
And this is the post-stent. We did a directly stenting, and here we used a 4 mm stent. 4 into 32 we used a stent. 4 mm stent is okay for this vessel?
What is the size of the guiding catheter, please?
This is 6 French.
4 may be small.
Okay. We thought initially it will be 4 mm. Then we dilated and we used a 4.5 mm balloon. We post-dilated, and there is no edge dissection, proximal or distal, and TIMI3 flow, and we thought it's okay, good result, and we came out. Now, this is after 4 hours. First nightmare started. Again, acute inferior wall MI, re-MI with bradycardia. Okay, first angio, there was no dissection of the edge, TIMI3 flow, everything is okay, no distal embolus, everything. This what happens. There is a proximal acute occlusion. We did a thrombosuction again. We removed the thrombus partly. And we gave a tenecteplase. Regarding tenecteplase dose, as you said, 1/5 of the dose you have to give. Most of the case reports, there is no clear-cut fixed dose. Reported 2 to 3 doses you can give. Rest of the things you can give through the systemic. That's what's reported. We, at the time, we gave a less dose, 5 milligram in this case, and we want to give a GP2 also. Glycoprotein 2B. We don't want to get a bleeding issue. So we gave and thrombosuction. Pacemaker was put at the temporary pacemaker since he had a bradycardia. And thrombosuction, then we can notice that entire RCA, that stented segment looking irregular. And we did again use 4.5 mm balloon. We dilated high pressure, and this was the...
But no imaging was done.
No, imaging was done at this stage. This is the balloon dilatation. This is the final report. He was on ticagrelor, loading dose was given, tica and aspirin. So now do you all accept this result is okay? There is a distal thrombus is there in a PDA.
No, I don't accept it. Because you haven't done imaging.
No. Imaging, I accept imaging, I have done everything.
Not available, you said?
Imaging was available.
Was not available or available?
It is available, we have not done it. And we thought that this okay, 4.5 mm balloon, high pressure dilatation 18 to 20. And there is a distal thrombus in the proximal PDA. And otherwise TIMI3 flow. Medically, yeah. We accept this as a good result. Again, second nightmare. Again, same story. Same ECG, different. You can see the different. Now I'll show you. Different. Now again bradycardia with almost like going to complete heart block. Now we did again chest pain. This is at evening 6 p.m. Okay. That's what we will. That's now again same area. Again he was taken, you see the proximal same area, again acute occlusion. Now again same all the intracoronary thrombolysis, balloon dilatation, thrombosuspiration, everything we did. Then we thought that it's repeatedly happening, then it is an ideal time to take for imaging. We want to know what exactly is happening, whether really was the problem with the stent or problem with the vessel or is any other issue. Now this is imaging we have done IVAS. We had an IVAS, we did an IVAS. Now IVAS shows that the vessel size is almost 5 mm. 5 mm.
That was my impression to start
Yes,
off with. Carry on.
5 mm. Now when we did an IVAS, it shows that the stent is floating. Areas, most of the areas it was floating. And we decided again do the thrombosuction, post-dilate. This time we used a 5 mm balloon. Aggressively we dilated. Then we used a 5 mm stent to cover distally. There was in IVAS was showing there is a distal dissection, edge dissection because of aggressive dilatation, and proximally also it was not looking very good. Then we took a 5 into 12 mm distally and 5 into 22 mm proximally to cover, and 5 mm balloon we aggressively dilated at 18 to 20 atmosphere pressure. And this is the second IVAS shows that stent is well opposed. There is no edge dissection any side. And this is the final result. So here is everything is okay. There any here also any issues?
If you've done the imaging as you, this is the end of the case or something else?
No, this end of the case. This end of the case.
We don't know. So
this end of the case.
I'm very sorry to interrupt, but at this stage I want to ask, in the first place, which of us would not have stented this, would have just left it?
I've just treated with the medicine.
No. So yes. So for large artery which is flowing, visible, large artery, long thrombus, we saw that in the beginning. How many of us would have just treated with 2B3As and then taken patient after
Vivek,
middle stage?
you saw
So
you saw only thrombus, but there was looks like a spontaneous dissection there in the proximal segment.
Shows spontaneous dissection?
It doesn't matter.
No, unless you have done imaging, ruled out is not a major
So
dissection.
Dr. Reddy, I'm saying on the basis of what we saw,
Yeah.
how many of us would have done it? And we see 5-7 people to do that. And I have to ask you one more question. When you had a problem and you have imaging on that thing, if a patient needs imaging, this is the patient where you had a thing. So why first time out of just...
It was the inertia, initially inertia to...
That's common for all of us.
Can I ask a question?
Yeah.
From practical, see the first index procedure, most of us would not have used imaging. It's a night PAMI. It's very difficult sometimes to exactly size the artery once the size is above 4.5. So what are the tips and tricks for correct sizing so that the index procedure itself we get a correct size? Can we?
I think in an acute infarct, remember one thing, that the artery is always a little vasoconstricted. You never get the right size. We always upsize by 0.5. Or sometimes if it's in the right coronary artery, we always upsize by plus 1. If it's a circumflex, then keep it just one size or upsize by 0.2, because in the circumflex is closer to the source and the image intensifier is away. So circumflex always looks bigger than what it actually is. Okay. RCA looks smaller than what it actually is.
So first time when you got acute stent thrombosis, what was the thought in your mind? It was under expansion stent edge dissection or under expansion of the stent?
We were thinking whether because of chemotherapy received, that must be the reason we got occluded. That we are not knowing what exactly went wrong.
And you went through and did the ballooning only. What you thought? It was
while this discussion is going on, can the next presenter load the slides and make sure it's running?
This is a takeover message, and there are other causes for the stent thrombus. One should look in procedure related, stent related, and medical issues. One just look in whenever there is an acute stent thrombosis. Thank you. With this, I think first we thought it is.
Amit, will you load your presentation, please? So,
Vivek,
so according to me, Dr. Reddy, thrombus begets thrombus. When you have such a large amount of thrombus, you're heading. You should be ready for a thrombus. And as somebody said, there's a long stent. The first stent was what, 32. So long stent, and for me initially also it looked less, which is why I asked you the size. So I thought it was a big artery and.
Yeah,
Sir,
what made you say 5, size by
No,
gross?
because when I looked at the size of the artery, and like Ajit clearly mentioned, I mean, all these arteries are vasospastic. They're layered by thrombus. I saw the 2 millimeter diameter 6 French catheter, and this didn't look like 4. So I thought the 4 was too little. And I'm not a big fan of imaging routinely, but if a problem arises, you should image. That's it. That's my basis.
Sir, my question is, if IVS is not available or OCT not available with you, what would have been your plan of management?
So first to start off with, I would never have stented in the first place. I would have given 2B3A or something, taken the patient the next day for looking at it. And as Ajit says, oversize the balloon or oversize the stent, but don't go to high pressures. That post dilatation at very high pressures causes a Swiss cheese effect or egg cutting effect, and you get all the thrombus which goes in distally. So I would have probably taken a larger 4.5 mm. If I was forced to stent in that particular case and I had no option, no imaging, I would have probably taken a little larger stent and go up gently to nominal pressure
Vivek,
types.
4 mm stent we dilated for second time 4.5 balloon also, high pressure.
You went to 4.5, yeah. But even that didn't look enough.
Then
Yeah, but there's another side to that.
Yeah, other side is always there.
You can have problems.
No.
Dissection.
Extremely difficult in
It's not easy.
best is avoid stenting if possible.
If possible in such a situation, because thrombus begets thrombus.
One quick comment on Dr. Melin's question. If 4O artery, I do balloon after the stenting, small balloon 4O at 10 atmosphere and just give the dye. If dye is passing through it, it means it is significantly small size.
Just 1 minute, Anil. Just one query, which I showed in CCA, We had a acute stent thrombosis following whatever distal diameter size, I think 3 by something. And then, then we did TA, intracoronary, all, masala and all. Then we got the flow. But the stent expansion at least were not adequate like. Now whether you have to go to the higher balloon size, Milind, are you here? Yeah. Then we went ahead with the little higher balloon because we wanted the good result, The point I'm asking, we say post-dilatation acute setting, we should not do. I know, but if the stent is not expanded or apposed well, what you're going to do?
You have to go up on high pressures, but this is nothing about what you do in these circumstances, and which many people do, is that you keep the balloon inflated for I would take a little longer balloon, keep it inflated for a very long period of time, more than 1 minute, 1.5 minutes, if the patient can tolerate it, and then slowly come down on the on the deflations. This has been shown to reduce the no reflow phenomena, especially when you go on higher pressures in an acute infarct situation. Stay at that occluded for a minute, minute and a half, if the patient can tolerate it.
Same size balloon?
Yes.
The thing that I do is I would give sodium nitroprusside to most of these patients. According to me, that helps a lot for microcirculation.
Chetan, bolna hai.
Better than sodium nitroprusside is
Because
let's go.
the moment you
Not difficult at all.
Amit sir.
No, I would have 100 times done it, and I have done it.
So
Sir,
because
next,
if you
please.
inflate and you deflate, the pressure reaches up to the umbilicus, it does not reach to the balloon.
Chalo, we need to move
So
ahead,
count
guys.
at least 30 seconds.
Amit, we need to start. Chalo.
Yeah, okay. I think I'll go, there's not much in this case. The plasty and all is not so much. So it's just the exercise complication. We thought that we should have one exercise complication because we don't see this very often. And Chanway.
You get exercise complication in the radial routes?
Yeah.
Oh, you do?
Very rare, very rare.
Where is apna?
Very rare.
Where's Bhavesh?
Yeah.
You're a femoralist, we know that, yeah.
So this was a 63-year-old lady, had recurrent chest pain since last 2 days, initially on exertion, then started getting in on rest. Admitted with almost early pulmonary edema, trop positive, was an NSTEMI, and patient also had moderate ischemic MR on the echo. So this is the angio. Okay, there is some disease in the LAD. The circ is 100% occluded, and there is lesion in the proximal RCA. Now, because there was an MR and this was an NSTEMI, we thought that the circ was the culprit because that was 100% occluded. So we thought we'll go ahead, spoke to the relative, do the culprit vessel plasty right now, and then think. Now, when I did the angio, we normally we put a 6 French Terumo sheath in the radial, and we use a 5 French Tiger catheter. So even when I was putting the 5 French Tiger catheter, I did have some resistance. So there was some radial spasm in this lady. And we were thinking whether we will get something when we are doing a plastic. So sometimes, when we removed the Tiger catheter and shifted to a guide, before that I gave a little more vasodilators, gave a little more NTG and some heparin. And then before taking the guide, we thought we will use what I have done in some cases in the past, do a mother and child. Take a long MP2 diagnostic and put in the guide and push it, because then the step up is not so high and the chances of radial spasm worsening or my guide not tracking is a little better. So circ radial, same 5 French MP2 as mother and child in a 6 French EBU 3.5 guide and C on wire, and then the plastic was okay. Wired, there was some pre-dilatation, there was no reflow, gave a lot of vasodilators, then put a stent. So stent is put and this is the result. This was the on-table result. Big circumflex, well open, patient did better. And so what happened is the patient, as soon as we removed the guide catheter and we were trying to put in the TR band, we found there was some swelling on the right forearm. Now this happens sometimes. A lot of times it is because of local edema there, and just using compression and some ice packs, and generally the patient becomes better and you don't really get a problem. The next day there was some swelling still there, so we got a Doppler done, and probably because of a lot of subcutaneous edema, the radiologist couldn't see any leak. So he said there's no leak and everything is good. So patient was put on anti-inflammatory medicines. We started using Maxelf cold compresses just to get rid of the pain and the swelling, and we hope that this would be okay. But the pain, the swelling persisted at day 4. There was no really auscultable bruit there, but there was pain, and so we thought let's go ahead and do a Doppler again. And this is what we found. We found there was that is a pseudoaneurysm there, which you can see in the right side, and that is the thrombus. So there was some leak which was seen at the in the mid forearm, so this is when, because there was some leak which was seen by the radiologist, we thought, okay, let's go back and get the VIR involved. So we called the vascular intervention radiologist. Dr. Abhijit Soni was the one who did this. So he said, get a CT done because we need to be sure what's happening. Is there really a leak? Because the radiologist was not 100% sure. So this is the upper arm CT. If you can focus here, you can see that at this point there is some pseudoaneurysm, some dilatation seen, and this is the part where there was some leak seen. So there was swelling, it's not completely gone away, some leak is seen, so what should we do, right? So the radiologist thought, go ahead, we'll coil the radial artery because the distal radial artery anyway is occluded, and we'll probably prevent this pseudoaneurysm from worsening and creating complications. So he went ahead, and this is the upper limb angiogram which was done by the radiologist. If you can focus a little as the vessel comes, at this point you see there is some leak which is seen in the radial side. Now this is, understand this is not at the wrist. This is, although the topic is wrist not healing, but this is much higher up in the forearm, and this is the plan. So he went ahead, he coiled, used the sorry, I'll go back. Yeah, so the Parksway microcatheter was used. Cook Nestor coil was used, and he coiled it, and after that there was no leak seen further in this. So after this the pain became better, the patient was okay. We repeated the Doppler once the patient got discharged after 3 days. Repeated a Doppler at about 7 days post discharge, and this is it, complete occlusion of the right radial artery. There is nothing, there's no leak in the pseudoaneurysm, and the patient did fine after that, right? So just quick review of literature. This is not very common, rare complication of a transradial excess. The incidence is very, very low, and it can be procedure related or patient related factors. So if you have multiple puncture at times, if you have a larger sheath, 6 or above, and if you've not really compressed the radial artery well, you can get that. And of course, we use in an ACS sometimes GP2B3 inhibitors, more heparin, and all that can contribute to it. most commonly seen in females, elderly females, more than 75 years are generally more commonly you can see this in this group of patients. It can also be seen when there is local calcification, because even if you compress the calcified arteries, sometimes you can't compress them well and you can get this complication, right? So what do you do? Of course, local compression works. You can do USG guided compression, which also works in some patients. You can do local thrombin injection, which I have not seen anyone do actually in the radial artery. We generally do this in femoral pseudoaneurysms, or you can just open and do a surgical ligation. So I had three cases of radial pseudoaneurysm in the last 20 years. For all of them were ladies. Female patients, all of them were elderly female patients. One was a 90-year-old lady where it happened after a diagnostic angiogram. There was local calcification and it could not be compressed by the USG guided compression, did not work. And finally I had to get my plastic surgeon friend to do a ligation of the radial artery under local anesthesia. The second was a lady, again inferior MI taken off of PAMI, again had something like this in the mid wrist, in the mid forearm. Went back and this USG guided compression worked and the patient became better. And the third case was the last case that I showed today. So radial vascular complication uncommon, but of course they can occur sometimes. 5 and 6 approach has helped me in the past to navigate radial spasms, but probably did not really work in this particular patient. Of course, if your catheter is not going, the most important thing is don't push. It's okay, you can always shift to the femoral approach. It's not necessary for us to do everything radial. A lot of the acute forearm swelling occurs, so if it occurs at least day 2, you should do an imaging to see if there's a leak. If there's a leak, we can a lot of times just close it by USG guided compression. It would work and would not need anything further. And microcoil embolization can effectively treat, like was done by Dr. Abhijit Soni in this case. And of course, parent vessel occlusion in the radial artery probably makes no difference, because we get this even when after doing a diagnostic or a therapeutic intervention. Thank you so much.
Thank you, Amit. That is a really good presentation. I have just one question. What 035 wire do you use when you use a radial routinely in all cases? You use the Teremo or use the...
No, I use the routine 035 wire. I don't use the Teremo.
Under fluoro or just until you feel the resistance?
No, so we don't really do fluoro all the way. But if the wire is going easily, then we don't. If I get a resistance when I'm pushing the guide, then I would probably go to fluoro.
So, Amit, 2 questions. Do you, when you puncture the radial artery, do you, as a routine, make a small injection to see the anatomy?
No.
Or no, you don't?
No.
Secondly, if you have a problem, like you sense something is wrong, what stops you from, like when you're changing over the catheter, to make an injection and see? That's number 2. And number 3, when you see a difficulty coming down, again, what stops us from injecting through the sheath before you actually put it out?
No, so actually so in this case, there was no problem when I removed. So everything came out very easily. There was not much spasm. And after that, we saw once we put the TR band, you remove the dressing and you see there's forearm swelling. Now, this happened in the past also, but most of the times you don't land up with a complication like this. Now, about injecting in the radial artery. Now, the problem with the radial artery is that it's a very small vessel. You might get some small leak here and there, and usually it causes no problems. If you inject in the radial artery, a lot of times, what I have seen in a couple of injections that I've made is that you see everything just filling up with contrast, even in your muscles and all. Because maybe there's a small leak somewhere, but that actually does not translate into a clinical problem. In the sense, you don't really have to go back, do a compression. Yes, I agree, if we get stuck somewhere, it's always good to do an injection. Now, in this case, because I was anticipating a problem, I actually started with a 5 and 6. I had very little resistance in the mid forearm. I had some resistance, I agree. I just waited for like few seconds and then I just pushed it and it went through. So I was not really expecting this to land up in a pseudoaneurysm kind of a picture. And like I've seen, probably 3 cases in the last 20 years, 8,500 procedures. I think it's not a big incidence, but yes, because radial arteries are very easily compressible. Also, even USG guided compression is very easily possible. So usually you don't land up in a complication.
Amit, my observation always under fluoro, I hardly put, radial wire without fluoro, unless our cath lab, that tube is something problem. Practically every time. I think that should be, I don't know what is the... Yeah.
Normally
other thing, what happened about the MR,
So the patient's MR decreased after 48 hours.
No, what
so
I'm
it
saying,
was mild.
acute circ occlusion,
Yeah.
you got a MR. Have we delineated what is the cause of MR? Is it like ischemic or a papillary muscle?
So it was, I think it was ischemic because it was moderate 2 plus 3 MR and it became 1. It was mild just before discharge. So I think this was an ischemic MR that the patient had.
I think we'll have a last comment here.
Just have a comment on this. Because my experience is the real problem comes because you cannulate the radial artery upwards blindly. Many times it goes into a smaller tweaks of the radial artery. So I make it a point that till I reach above the elbow, I always do fluoro. It involves some radiation, but I am telling you that way I have never had any problem. Otherwise, you will realize it much later because those tweaks start slowly oozing out, and by the time you finish your procedure, there is some swelling. So never go till at least the elbow. You go after that, it's a big artery, so nothing happens.
Other thing, Kani, in addition to that, when this wire is going and making a loop, that means, it cannot injure the vessel. Then you can, like generally elbow or above that, but under the floor always, I think.
Okay. One small comment. There is a new hydrophilic baby J wire from Terumo, which is a 1.5 millimeter J tip and a hydrophilic, and not a double length but extra length wire, which we can use, and it slides in, doesn't go into the branches, and it's very easy to avoid the side branches. It also tracks along the radial loops, and it straightens them. Because of the very small J tip, it's really very useful in such cases.
So just one last thing. So what happens is sometimes I don't use Terumo generally in my radial because Terumo walks in through any branch very easily, and sometimes you have an accessory radial which is a very small branch. So your Terumo will go, your 5 French will go, but your guides never go.
This is not the angle.
No, I'm not talking about this. I just said because we were thinking about, because there are a lot of youngsters I've seen using Terumo in a radial. They start with a Terumo and a 5 French Tiger, but I think that's not a very good idea. I personally think it's not a very good idea.
So this is almost like a U-shaped small, so it doesn't really dissect.
I think we'll end this session over here, and thank you to all the speakers. Dr. Milind, you can take over.
Thank you, speakers and chairpersons, for a great session. Now, for the second session, I would like to call the chairpersons Dr. Punamya sir, Dr. Sunil Vani, Dr. Chetan Shah sir, Dr. Girish, Dr. Chirag, and Dr. Suchit, and they can then take over the proceedings, please.
Good morning, everybody. So, this is my complication case. DCB, not always a bed of roses. So, a patient is a 37-year-old female who came to us with a new onset of crescendo angina, started off with angina on minimal exertion and then started developing rest pain for about 10 days. She has a very bad family history. Both her parents had a sudden cardiac death at about 45 to 47 years of age. Her LDL cholesterol was about 160 and her LP small a was 84. Her ECG had subtle T-wave inversions, nothing great, and echocardiography showed a apical LAD hypokinesia. With her very typical unstable angina presentation in the setting of high cardiovascular risk, we straight away took her up for an angio. We went through the radial axis, and this is her LAD, which shows a 95% stenosis, focal lesion just after the diagonal branch. Circumflex, ramus, and RCA were normal. So, in this setting of a young lady with a focal lesion in the LAD, we thought we'll go for a provisional DCB strategy because of her young age, and we thought it will mostly be a lipidic soft lesion. We would avoid stenting in such a young female. So, because the radial was small, we just switched to a femoral axis and engaged with a routine EBU guide, workhorse wire. And this was a predilatation with a 275/15 non-compliant balloon because of the strategy to try DCB if possible. And there was a lot of slipping of the balloon initially, but then finally we were, with slow inflations, able to catch the lesion. And it did slip a little bit, but we were able to catch the lesion. And this was the shoot after the NC balloon. And there is some residual stenosis, there is some haziness, so we were not very happy with this balloon result. So went ahead with a 3013 aperta scoring balloon and went up 3 to 4 inflations at 16 atmospheres. And fortunately, this balloon seems to be much better expanded as compared to the NC balloon. And this was the result after the scoring balloon, and there was no significant dissections. There is a TIMI3 flow down in the vessel, so we were pretty happy with this. So we decided we'll go ahead with a drug-coated balloon implantation. So 3025 paclitaxel DCB, 7 atmospheres, up for 60 seconds. And this is the final result. So at this point, we were fairly happy. Patient was stable, shifted to the ICU and went home the next day with aspirin clopidogrel DAPT. This was done on a Monday afternoon, and she came back on a Sunday afternoon, about 5 days later, to the ER with similar angina and very subtle elevation in the anterior leads of about 2 to 3 hours. So with a high index of suspicion, we just straight away took her into the lab and engaged the left with a guiding, and this is the picture. So the LAD actually at that point has completely abruptly occluded, and now we've caused a MI in a NSTEMI. So this pre-dilated with a 2.5 balloon, and you can appreciate the thrombus and sluggish flow into the distal vessel. So gave her dilators, established better flow down the vessel, and now no, we didn't have any more bravado, so we just stented it with a 3034 DES and then post-dilated with the 30 NC balloon. And this was the final result. The very apical LAD, there is still a distal thrombus which was managed with GP2B inhibitors, and now she was switched to prasugrel and went home after a couple of days, but REF did drop to about 40-45% and the apical LAD territory became hypokinetic. So why did this happen? These are my theories. There may be a non-flow limiting dissection which caused superadded thrombus formation, but personally I feel that it was a lipid-rich plaque with probably a plaque rupture, and when we stent it, we actually give a scaffolding to cover the vulnerable plaque. In the DCB, we are not giving that effect. We are not having a scaffolding of the stent material, and probably the lipid-rich core was still exposed to the lumen, and that caused a superadded thrombosis. There may be clopidogrel resistance, we are not sure, but we did switch her to prasugrel after stenting. We did not image. I am not sure how imaging would have added too much information. We have been routinely taught that in DCB we can accept medial dissections. We would probably have seen a vulnerable plaque with good luminal gains. Would that have changed anything at the time of the index procedure? I am not sure, but I'm open to comments. Maybe we should have put her on a newer antiplatelet right from the beginning, but we thought she's a young lady, menses, excessive bleeding, so we thought we'll keep her on clopidogrel. So this is where we are. Literature says, so why stents were invented in the first place was because abrupt vessel closure was common after balloon angioplasty. A lot of articles, meta-analysis say that the chances of vessel closure after DCB is less than 1%, and it is actually equal to or lesser than stent thrombosis. But there is also then data which says that only 94% of the dissections are healed on follow-up angiography. So are we ready to accept 6% non-healed dissections in large proximal arteries? Leaves food for thought. There's a lot of gung-ho, like everybody's gung-ho about doing DCB nowadays. I, after this experience, am sort of going back in terms of doing it in large proximal vessels. I still think it works very well in side branches and distal vessels and ISR. Would I want it? I have not done it again now for proximal vessels. So again, I think maybe after a few weeks when I'm better off, then maybe we can think about it. But yeah, open to comments and suggestions.
Comments from the house?
Only thing here, it's a large artery, acute stent thrombosis. What is the mortality rate? That's one thing always DABE in a proximal versus, as he mentioned, side branch, diffuse disease, where we can't put the stent. There's one trial which recently came even in a proximal artery, both DABE as well as DABEs, which is, I don't know, Sentinel or some trial, So which is, they said it is reasonably good. So it's a really very bad thing, because you could lose, She's a 37-year-old. We could lose,
Yeah. So I agree with this. I personally am dead scared of using it in a proximal large vessel, especially LED. I never use it. So what you said right at the end, the indications, they remain the same for me. Distal, side branches, ISR. And if a person who has already infarcted in anterior artery, if I may be doing a plasty, maybe I will err on using a DCB rather than that also is not correct according to me. Because I always ask this question to the people from Europe who are pressing for this, two things. What happens if the artery closes? So I asked Antonio Colombo. You have to accept it. That was the answer, but that's not the answer I can accept. The other thing I always have a problem is most of our patients in the Indian community at least, whenever I have used a DCB, they have asked me, why have you not put a stent? Doctor, stent nahi dala? Kyun nahi dala? So what are the medical legal implications of this question? I am really not sure. If anybody can help on this, I would be appreciative.
Chirag, can I, before you, Chirag, firstly, thank you for presenting this case, because it's, for most of us, it's a case where we would never have brought this issue up. For most of us with the grey hair, we wouldn't dream of leaving this unstented. Proximal LED, to not put a stent, is in my eyes, unacceptable. Okay? My eyes.
Sure.
And now I'm sure you will also, but you are a victim of marketing and of, according to me, I'm sure Kirti will have something to say against that, according to me, of misinformation, which has been directed to a large extent by Antonio Colombo, who got tired of stenting vessels and found out other ways of doing the same procedure. So the DCBs have been around for 12 years, but now they've been resurrected. Now, and Antonio Colombo does it under imaging and makes sure that everything is fine is quite different from what you and I do. Wait a minute. So you can contradict me. But for a proximal vessel like that, I mean, whatever anybody may say, I'm not going to leave it unstented.
I asked Dr. Colombo in a meeting in Bombay, what about imaging? He said, I don't use imaging. That's what he answered to me at that time. Because imaging was not there. Because I participated in a debate on imaging versus no imaging. So before starting the debate, I met him in the coffee house. I asked him, sir, what about imaging? He said, that's not established as that. I don't use imaging.
I think with the first ballooning 2.75, there was haziness. Yes. It says there's something is there. There may be some plaque rupture. With 3O, with this cutting, you have pressed it. So without imaging, putting a stent, I think it is very, very risky.
Sir, that's my question.
Stent.
What additionally on imaging would have pushed you for stenting?
I think this whole thing about DCB is overhyped. And to me, it is only small vessels where we cannot use stents less than 2.5 millimeter, side branches, small OM, small diagonals, which are giving rise to angina. But I think it is not there for big proximal vessels, big no-no, and I am really thankful that you have presented this case to give a message that DCB is not there for such big vessels.
Chirag, why not if big vessel there is no dissection on imaging? Because drug-eating balloon is just
So there are two things. The question is, when you're looking at proximal LED, left main, proximal dominant circumflex, proximal RCA, there's no randomized trial to support DCB use because these arteries are 3.5 millimeters and the plaque volume is so high that I think we don't have the current technology to support this and we don't have data to support it. So we are on a limb, as Kane said, that if we don't put a stent in the proximal LED, then we can be questioned why not, because the data to support DES is so strong and the TLR rates and the MACE rates are so low that to better that, I think DCB is not up to it at the moment. That doesn't rule out DCB from other areas. That's one. Two, angiographically looking good in a proximal LED does not mean intravascular imaging looking good. And I think that is a distinction that you need to make now. Your problem partly is that you took up an angioplasty, did something out of the box without imaging. And I think that if you're going to do something out of the box, you need to be doubly sure that you're doing it right. Two, And a lesson that I've learned is that if you're going to look at arteries, even in 2.5 millimeter arteries, we first prepare the lesion and then we wait for 20 minutes. And in 20 minutes, most of the arteries will show their face. If you had waited long enough, you would have shown that there is haziness coming into the LAD and you would have stented it even before. So when you're doing something like this, my policy is wait for 15 minutes, do an IVUS run and see the loss of MLA. If the loss of MLA is huge, stent it.
I'm sure you would have waited, Chirag. You waited.
Sir, it happened after 5 days. So that's my concern. So
Antonio, Dr. Kane, Dr. Antonio Colombo also says he said 15-20 minutes. 1 minute, elastic recoil. I'm just saying.
No, I'm sorry.
No, in one of the meetings.
I've had a chat with Antonio Colombo when I met him in St. Louis this time, and I told him, I'm sorry. Nothing happens in 1 minute because 1 minute it takes for me to do an IVUS after a PCI. It's when I wait for 10 minutes, I realize that the artery starts recoiling. Okay. And unless we wait for 10 minutes, you're not going to see it.
You see, this was what we used to do when we did not have stand.
Yes, yes.
Yeah. If it does not collapse, it's a picture. Otherwise,
Achha, no imaging post DEB, na? Any imaging post DEB?
Imaging post DB is not essential. If you do it at 10 minutes and then finish off with a DB, you don't need it.
No, usually not recommended.
1% at a time. So everybody knows that large arteries have not worked at all.
Yeah, so that's just reconfirmation of all of us with the grey hair. So Chetan has grey hair, he has white hair, everybody has. Kirti has grey hair.
Just to play the devil's advocate, his angiogram result was good. Let's assume he did the OCT or an IVUS and everything looked fine. Would he be still allowed to leave it alone? That's one. Second possibility, why are we not thinking of a small chance of a clopidogrel drug resistance, for all you know? After the stent also, it could have closed maybe if he was clopidogrel drug resistant, the patient.
See, I tell you, it is not a stent thrombosis. This is an acute closure. There is no stent over there.
I'm saying if he had stented.
No, even if you didn't stent. This is not a stent occlusion because there is no stent. So you cannot talk about clopidogrel resistance over here. This is a mechanical failure at 5 days. Yeah. And that is what you need to understand. This is a pure mechanical failure. And even if it came back, I think you should have taken that little step to see what caused it by doing an imaging at that time, because otherwise we don't learn anything.
Kirti sir, near-iris IVUS would have been helped in this case to find out
which one?
Near infrared spectroscopy. Would have helped to document the lipid core, how much is and whether high lipid burden.
So his problem was not slow flow with the dilatation. His problem was mechanical problems, which we are talking about. So any IVUS would have helped, OCT would have helped, anything would have helped.
Near-iris will tell you the lipid core burden index. If it is high core burden index, then I think usually probably go for a stenting. If the slow burden core is and a
So we don't have that data right now. So you cannot make that comment.
He is also a case of PCS, acute situation.
So right now she's on rosuvastatin, peptide acid. When she comes back, we'll see the lipids and
I think let's close this. Yeah, let's move to the next.
Good morning, everybody.
Well done.
I have 2 cases to present. I'll try to finish in time. Case 1 was a 72-year-old female who presented with inferior wall MI, was lysed with tectoplasty 12 hours back in an outside nursing home, transferred for PCI early morning. Her risk factors were diabetes, hypertension, dyslipidemia. Ejection fraction was 45% with inferior wall hypokinesia. On coronary angiogram, the left system was largely unremarkable except an isolated lesion in the ostium of the diagonal. However, the culprit region was mid-RCA, tubular lesion, slightly thrombotic. So I proceeded with a 6 French guide via radial route, passed my workhorse wire, and prepped up the lesion with a 3015 balloon. The results of pre-dilatation were good, so I went ahead and stented it with a 3.5 into 38 everolimus eluting stent, inflated up to 14 atmospheric pressures. After the results post-angioplasty were also good, so I decided to go ahead and do post-dilatation with a 4012 balloon. And the moment I was dilating, the patient started complaining of chest pain, profuse sweating, and bradycardia. and there was massive perforation there, Ellis type 3. So I took the same post-dilatation balloon to tamponade it. Meanwhile, we could get the cover stent. And then after getting the cover stent, which was 3.5 into 19, I went ahead and sealed the perforation with the cover stent. I had to give during that phase 1 dose of termin and 1 bolus of epinephrine. After that, the BP had come up, but the BP was still on the lower side, which was due to a large perforation, blood accumulation in the pericardium, leading to cardiac tamponade. So I went ahead with pericardiocentesis, and 200 ml of blood was aspirated. The hemodynamics improved. After that, the patient was shifted to ICU. 24 hours later, the sheath was pericardial sheath was removed, and there was no further complications. Patient was discharged for 72 hours later. This is the first case. The second case is an 80-year-old female who presented with inferior wall MI with CHB, and her risk factors were only diabetes. Her ejection fraction was 35%. This is the right chutes. The left chute, the left system had a discrete lesion in the circumflex as well as the mid LAD. The RCA was severely calcified. Proximal RCA was the culprit, I thought, but there was in the mid RCA also another calcific portion. The patient was already on temporary pacemaker wire when she underwent angiogram. So after engaging with a via femoral route with a JR4 guide, I tried to pass my workhorse wire, but it was getting stuck in some upper portion. So I used a micro catheter, but was not able to. So in spite of using multiple soft wires, I was not able, so I took a stiff wire and was able to cross the RCA with the help of a micro catheter. However, I balloon dilated that portion, and once you can see that there is a small perforation here. So I withdrew the wire, and then with the help of parallel wire technique, I again put the wire into the true lumen. Probably the earlier perforation was because I balloon dilated, the wire must have gone into the false lumen. So here, after passing another stiff wire, I had no option, nothing was going through, and there was still leak, although the hemodynamics were stable because it was a wire-induced perforation, that's what I thought. So I balloon dilated sequentially with 1 millimeter, 2 millimeter balloons, and you can see, and then 2.5. The perforation kept on increasing, but the hemodynamics were relatively stable. I just thought that maybe once we stent it, I called my surgeon friend also, that time it was early 4 a.m. in the morning, and then, but after, again, the stent was not going, so again I dilated it with a 2.5 millimeter balloon, 2.5 into 12 millimeter balloon, inflated up to 14 atmospheric pressures. Still the stent was not going, so I had to take the help of a guide point, and after that I was able to implant 2 overlapping stents, 2.75 into 34 and 3.0 into 34, and finally the perforation sealed after implanting those 2 stents inflated up to 14 atmospheric pressures. This is the final result. The take-home message is, in large vessel perforation, once you know that it has happened, be ready to put in a cover stent and do pericardiocentesis. There is no point in panicking that it has happened. These are 2 steps. In a wire perforation, things are relatively stable, so you can balloon tamponade, you can stent it, you can coil it, you have some time. But in a large wire perforation, you don't have much time. You have to be quick. That's it. Thank you. I hope I'm in time.
So the only one single comment I have is I disagree with this slide, because wire perforations are not simple as well. It can be very nasty. It can be more nasty than other.
Means I meant you have time. I meant you have time, unlike the large.
No, not really. And I'll show you cases where I've not had time.
Looking at your first case, I think balloon oversizing. Second, what I would have done different is, I think, a ping pong technique, so it would have saved some time. You would have not got actually to really put a pigtail or something. So you could have taken a second puncture and put your covered stent.
No, second I did not put, the first you are asking a cover stent. First case cover stent.
So you put, right, covered stent?
Yeah. No,
so
already
you can do a ping pong technique where
I agree. You can do a ping pong, or you can
went with the balloon, then you got the balloon out, and then you put the cover.
You can do a ping pong. You can inflate the same balloon, shove your guide inside, and do all those. But the point is that I was very confident that the stent has been dilated. My cover stent would not give me any resistance. So let's be quick and finish it off. I got your point.
Leaking. So
yeah,
you hold your balloon there. Yeah, that's what. So you'll save your leak and you don't have to. Yeah. That's what.
But Sunil, by that time, no, I'm telling you, by that time, you are quick. Sunil, by that time, you are telling ping pong technique. You have to take puncture when the patient is having a BP of 60 systolic. So better.
You have already put the balloon. That will tamponade.
Yeah, but the BP had gone down.
So let me intervene. Maybe, on a given day, this might have worked. On another day, you might have to do the other way. Yeah, that's one. Two, when you did the second case, did you do an echo post to see if there was a tamponade?
Yes.
Was there a tamponade?
No.
There was no pericardial effusion as well?
No. Minimal pericardial effusion. Minimal was.
Oh, and did you monitor this patient for later?
Yes. 72 hours later, the patient was discharged.
Just one caution here. Sometimes there is a minimal pericardial effusion, and that tamponade is enough to prevent you from seeing an angiographic leak. And the minute you tap it and relieve that resistance, you'll see the leak again. So I'll show you a case like that as well. So sometimes just be careful of that. Yeah.
But Kirti, just a little rider on what you said. I sort of agree with Akbar where he says that a wire perforation at the site of the lesion is benign compared to a balloon perforation. One you are talking about wire perfs are probably distal wire perfs. So we will
look at distal wire perfs at all. I'm talking about wire perfs at an actual scene.
At the lesion, yeah. Okay,
we'll show you stuff.
They are generally, but we'll see. They're generally not as bad as a balloon perf.
So there is no generalization in this. Anything can be very bad. So when you see a perf, you've got to be very alarmed. Yeah.
We'll go further.
Let's move. Yeah. Thanks. What a great case.
Gaurav, thanks for coming from Nasik.
So it's my honor and privilege to be here. Thank you, CSI Nasik. Thank you, Amit, Dr. Milind, and Nihar, of course, for inviting me. And CSI Mumbai, sorry. So it's an honor to be in presence of an august audience. So I'm talking about complication. Nobody wants complications. So if you don't want complication, don't do cases. But complications tells us how you manage, how you learn, and how you improve your chances of decreasing them. Calcium is our biggest enemy, not only about the stent delivery or decreasing expansion, but also increasing the post or pre-procedural complications. And the complication, along with the lack of skills, are the major factors which inhibit to do some complicated cases. And also there's a belief of skewed risk versus benefit. Operators are not willing to take that chances, and also there's a punitive attitude that if something happens, people will be always against that. Medical therapy would have been better for such high risk cases. So there's a concept of forest and trees. Forest means what is known to all of us is about a global scenario, global complication rates. And whenever we find the rates, what we find about the complication in a complex intervention like calcific, we can have around 3% or 5%. In some studies, it may be around 10% of complication starting from perforations to vessel closures to inability to pass stents or restenosis further on. So, but more important is to know about your skills, your rates, and how you examine yourself or your data. That is more important. That is the concept of trees. That whenever you do some cases, you should have a predictability of the complication, the construct of the case. You should know what the event was there which led to the complication. It's not about inflating a balloon or inflating a stent, but always an event prior. Probably you were subintimal, you inflated a bigger balloon for pre-dilatation or maybe many other such cases. Then what treatment did you do and how did you improve in improving such cases the next time, and what was your lesson learned? So for calcific strategies, we have imaging which guide us to take up the special balloons or the special equipments or atherectomy devices when you have calcium, and especially when you have intimal or very high load of calcium, then you do atherectomy devices. And we have three atherectomy devices available. Laser is, that notch not very much easily available, or the experience is not that high. So rotational and orbital are the things what we usually do. Both are having the same DNA, have the similar type of function, but they differ in type of their functioning and somewhat safety. So this more than a written complication, we fear all these complications. When you have smaller size, the risk of perforation, you can have stuck burr, no reflow, and you always afraid to do in a tortuous artery. And these are all complications which you can encounter when you are having these kind of atherectomy devices. So first was by overconfidence, which led to the downfall. This was a highly calcific and multiple banded artery. So I thought of doing a orbital atherectomy instead of rota for the bends. So I did orbital in the proximal and the mid. Easily it could cross, but it was not crossing in the mid and the distal bend. So initially the speed was 80 km. Movement we tried 2-3 times, but it was not moving. So we increased the speed to 120 km. There was slightly brisk movement. The burr slipped into it, and you can see the burr will slip. After that, patient had some uneasiness, some chest tightness, and there was some perforation there. So this was also okay. It could be managed with some inotropes and some sedatives. So we thought that we'll cover it with a covered stent. We tried to cross a small 60 millimeter cover stent with a guide liner, but it won't go in. As we was trying, the guide disengaged and everything came out, and we are left with this. So we started again, and it was now carryable with the run-through wire, and luckily I could cross. Then I did a serial dilatation with NC balloons. Again, there was, because of bends and tight stenosis, it was not able to pass. I again took a guide liner down and tried to pass a graft stent. Again, it was not crossing. So what I did was I covered it with a flexible 3x48 DES. That will give me some room, as well as it may heal that perforation. But perforation persisted, and this time I could luckily pass a stent graft as well. So stent was put, and this was the pre, and I could finish it with this. Another complication was when the patient has a low EF, then it is more dreadful because you don't have a chance. This was a 75-year-old male who was a post-CABG candidate, severe unstable angina, LVF 25%, diffusely disease, LAD as well as circumflex. So we put in IABP to start with, and TPI also put. And you can appreciate the calcium across the whole length of the LAD. Started with slow and steady standing with the orbital. Multiple attempts were taken. We could cross till the mid segment, but probably the distal segment, we were not able to cross across. We tried multiple times, maybe 8 to 10 times, but the distal part, this one was not passing through. So we increased the speed slightly. It bent, and then it got stuck. So burr got stuck, and we have to remove everything out. And then we restarted, and this time we did a rota to that area, and we could finish it with 2 stents at this segments. But the story doesn't end here. So we fixed 2 stents in the LAD and could finish that LAD, but the story was still there. So when we did orbital to the circumflex, there was a big perforation. And probably we were overconfident to do in such angulated circumflex, and this is how you get, lesson to be careful in these kind of settings. So we did a graft stent, and finally could finish up with this results. Third was about an old patient in which we were too steady and slow to do a good job for orbital standing. This was an old 87-year-old male, unstable angina, diffuse triple vessel disease. Option was bypass, but age and creatinine was the determinant which led to us to think about angioplasty. You can appreciate the diffuseness of the calcium and the disease. So we opted for orbital for the reason that we fear some perforation with these bends. So plan was to do orbital to both LAD, L6, and then do a bifurcation stenting. Started with orbital, with LAD. We did aggressive sanding, but very slowly and steadily. We took 8 to 10 minutes, and multiple runs were taken both antegrade and retrogradely. Post atherectomy, the flow was good, so thought of that we have done a good atherectomy, so we shifted to circumflex. As I was trying to remove my micro and shifting to viper wire, suddenly patient had some uneasiness in chest. This is my micro in circumflex. Patient was restless, and there was hypotension, tachycardia. Took some shoot, and I found that LAD is closed down. So there was thrombotic occlusion on LED. Immediately I could track because the atherectomy was done nicely, so my two stents could track down easily. So I just stented the mid LED. I thought of doing a proximal, but I thought I'll wait, and the flow was good. So I thought that flow is good, and I then go ahead. I should continue for the circumflex. But now circumflex is occluded. Now this was the major problem. Why? Because it has not been done any calcium modification, and now this was the biggest challenge. I took wire, balloon, nothing was crossing because of calcium. Now what to do? Patient was becoming unstable. So what I thought that I'll just fix the LED first, so that even if the circumflex I'm not able to do, my patient may not collapse on table. So what I did was to maintain the flow in LED, I fixed one more stent at the ostium so that should not get closed, and that gave me some time to work around circumflex. Then I did orbital in circumflex to around 4 runs, and then serial dilatation, and then I could finish it with a decent result and could manage and save myself. So next complication about this highly tight and calcific left main bifurcation disease, new onset angina in 58-year-old male who has a normal preserved LV function. Thought of doing a provisional versus dedicated. I was worried about that angle of circumflex. That was a very acute angle, that if you land up after provisional with some problem, then it may be difficult to tackle that. But still we thought of doing a provisional stenting, and sequence was to first fix this small OM and mid LED, and then I'll put a provisional stent to left main to LED. Did 20-second burr, 6 runs in LED. Post atherectomy did balloon dilatation. Put a stent in OM and mid LED. And when I did a provisional stenting, the circumflex have occluded. And this was the biggest challenge because of the angulation and that stent across that left main. Patient was again becoming restless, hypotensive. So I took desperate attempts to cross, and finally, luckily this Gladys wire could cross. Did a serial dilatation, then did a T-stenting with the help of a guide liner, and I could salvage the patient. This is another one patient. Just 2 minutes more, last complication. So this was a complication which was not anticipated for orbital, but you never know what can happen with the cases what you are dealing with. So this was a 72-year-old patient, constable angina, multiple diffuse calcific disease, and what the area I have highlighted is a small vessel, and usually the atherectomy device is not indicated for smaller vessel less than 2.5 millimeter. But I thought of that we can go ahead with that. So I shifted to circumflex, gave just a single run so that I could make some way for the balloon. I was really anticipating perforation, maybe a possible complication, but I could go ahead with that, and I could just make a single orbital run about that. But after this, the problem was that my balloon was not crossing. I tried with multiple balloons, 1.25, but it was not crossing. So what I thought of, that I'll take a help from the LED. I'll just...
Gaurav, we won't be able to discuss anything.
Okay,
so
fine.
You show us what you want us to discuss.
Fine.
Yeah? Let's open this to discussion. Yeah?
What I want is, we would want to have this discussion after your talk. Is that okay with you?
I have no issues.
Yeah. Gaurav, you are around now?
Sure. Yeah.
Because let's have the next talk, and then, because the complications are similar sort of a thing, maybe, I don't know, but we'll discuss it on that. Yeah.
Well, thank you very much. We'll move on to the next session. Can we have Dr. G.R. Kane sir, Dr. Bhavesh Wazivdar, Dr. Anil Podar as our chairpersons, and Dr. Tabassum, Dr. Somnath, and Dr. Vivek Mahajan as our moderators. And I'll have them introduce our speaker.
Dr. Mahajan is not here, so I request Dr. Girish to sit and help us out with the meeting. Yeah.
Thank you. Thanks. Thank you. Can you give me the screen? Yeah, right. I got it.
Kirti's talk. Yeah. Hi. So next is our state-of-the-art talk by our own Dr. Kirti Punamia. He doesn't need an introduction. But I'm always fascinated by his work and his nature of the work he has been doing and presenting also. He's one of the excellent speakers that I know of. So let us listen to him, and then we can have a combined discussion of Dr. Gaura's cases and Dr. Kirti Punamia's presentation. So from Gori to glory. Oh, nice. Yeah, okay. Please go ahead, sir.
So this is one of those humbling moments in cardiology where you start off as a cowboy and you think you can conquer everything, and we've all been through that. And then as you get to my position over here, you start getting you get a little wiser, and you realize that there are a lot of things we can't do or we don't do them correctly. But that is almost always a hindsight reflection. I thank Kane and I thank CSI for giving me this podium. And I just show you things over the last 15 or 20 years of how things have happened in my cath lab. And I start off with this very, what I thought initially was a moderate looking RCA, complexity level maybe 6 or 7 on 10. But what is interesting is that a very good colleague of mine had attempted it, and he got the wire into the PDA, but he couldn't track other devices. So he called me and he said, Kirti, we have a problem. Can we do it? And I said, why don't you get him along and we'll get this going. So we got him into Bridge Candy Hospital. We got him back for another attempt. And the question was, we could have treated him medically because his left main to LED was stented, but he continued to have chest pain. So we tried to treat his anemia, tried to do everything, but his chest pains were bothering him. And we started off, we had a wire across the mid-RCA, and a microcatheter failed. So we had choices. So we did a rotational atherectomy, and for a very long time, this is 50 minutes, now almost an hour into the case, and I'm not able to get across that rotablator. So we used an LCA to see if that would work, and the LCA, I didn't have a purchase beyond this because there's so much of flaky calcium that I didn't have movement. We did a balloon dilatation post that rota, gave me a little small balloon and then went up to bigger balloons, and we got purchase into that artery. And I was thinking if I can get my guidezilla beyond that first block, then I have access into my distal block, and then I can kind of go through a wire. And so to anchor it, we put a balloon there, and my guidezilla will not track in spite of good dilatation with a 3.5 millimeter balloon. And this is when angiography at this time, I said, okay, fine, if I've got some flow into this, let me see if I can get a wire into the PLV. The wire into the PDA was not a problem. The wire was in the PLV because the PLV was a much larger artery. And in that time, what happened is I made those attempts, and while I was crossing, I realized that things were not looking good, getting a little hypotensive. And in that whole disaster, one little coffin, we lost everything. We lost everything, flipped out. And marked bradycardia, hypotensive, on the ventilator, acidemia, BP not responsive to noradrenaline, we lost him on table. So this is the most humbling moment where you lose a patient on table. The question is, have you taken a consent for death? And sometimes that is the biggest problem. So I think one of the messages from here is that all of us can have this in our cath lab when we do these kind of cases. When you talk to the patient, tell them that death is a possibility, and make sure that we take written consent on that. It's a very important thing. There are many ways to have modified this and made it different, but that is not the point of this discussion. The point of this discussion is how can we prepare ourselves for the worst outcome in the cath lab? Because by law of probability, it will happen once in your lifetime at least. An 86-year-old male came with angina of effort, bothering him. Heavily calcified tortuous CTA. You can see my CTA shows that it's a pretty nasty right coronary artery. And this is his right coronary artery, very large. Now, my problem was we have a proximal shepherd crook. We have a very large, nasty, you can see the calcium dyspora. and there's a large calcified lesion. I mean, if you look at this soft lesion downstream, has a calcium block in front of it. So with that, I said, let me get a microwire in. Microcatheter went that far. It struggled, but I was able to get a wire inside. And then I said, okay, let me do the orbital. And so we did an orbital. And this was a 1.25 crown like usual at 80, a few smooth runs, went across, and we went pretty good if you went all the way in. Actually, my orbital actually went all the way in, and we did. But I said, okay, let me do one extra run. And when that one extra run, there was a little, and this was perfectly fine till what happened was the last run over here, 1 minute. Look at this run. It comes back, and it's coming on easy. There's nothing happening at all. I go back inside, and I come back. And when I pull it out, see what happens over there. Can you see it disconnects? Can you see the fracture? The crown fractures off. So what happened over there? Any guesses? It was smooth. I had no resistance. No, there was no resistance at all. So what happened? I've done this 3 times now. And what happened? No. The wire was perfectly normal. So the rule in orbital is that you don't exceed your run to more than 30 seconds. Here, I went to almost 40 seconds. And when you go to that run, the orbital atherectomy device, the crown goes through a fatigue. You have to release that fatigue. So limit your runs. What I should have done in this run is when I went into the distal artery, when I came to the mid-segment, I should have stopped the run. And it should have been another run for me to come out of the artery, and I would be fine. A lesson learned. Be careful. Orbital, don't exceed your run to more than 35. You will fatigue the crown, and you may even fracture it. And we pulled it out. The problem is, we pulled it out, and the artery had closed. So here, I had a little bit of a hypotension. This patient suffered a myocardial infarction. We gave him noradrenaline for 48 hours. His EF had dropped to 40%. I followed him for 2 years. Fortunately, now I give him an infarct, so he doesn't have any angina, thankfully. But it is, I'm sorry. I know we have a warped sense of humor, but I want to make this a little... Sorry?
Still alive is great. Yeah, you kept him alive.
No, I have not kept him alive at all. Despite my best efforts to not keep him alive, he's alive, I think. And that is the lesson that I want you to understand and take home from him.
Boss, the late Dr. B.K. Golsar used to say you should know when to stop. That's why stopping correctly. What happened to the fractured crown? There inside.
So exactly, no. The fractured crown, I put in the guide catheter a little inside and I pulled it out. It just snapped out and came out. Yeah, so the wire is great the wire is strong. It allows you to pull out the crown. And there was no resistance. And so it was easy to pull out. The problem was the fatigue. And you got to remember that.
And the wire, distal wire is...
So when you... So yeah.
It is going to come.
It is going to come. It's like a rota, right? It will pull it out. Yeah. So a 73-year-old lady who came to us with acute coronary syndrome with rest ST segment changes. She had this disease in the left coronary artery, which looks nasty, and the right was the culprit to some extent. So we fixed the right and got it right. But once I fixed the right, the collaterals were such that I had lost the antegrade flow in the LED. You can see that. And so if you want to have perspective on this, you can go back to the last picture again. This is the left, where you can see some flow. You can see 2 CTOs in that LED. And you can see a right coronary artery there. And this is the left. So now the question is, we have to deal with these 2 CTOs, right? And fine cross microcatheter with a UB3 wire, difficult to move the wire beyond the first CTO. I'm not able to get past the second CTO. Cannot advance the microcatheter beyond the first CTO. I'm stuck. I go and do a laser, and my laser allows me to cross the first CTO, but it doesn't go anywhere beyond that. So I said, okay, fine. And post laser, I'm able to get my microcatheter into the lesion, and it comes to the second, just before the second CTO. Can you see that the microcatheter has advanced a bit? Now my microcatheter doesn't go, and here the story that I haven't mentioned in this is that when we did a UB3, we did the UB3, then we tried with the Gaia next, and then after that we went back with the UB3, and the UB3 finally went into the True Lumen. But I couldn't follow any devices here. So we are stuck at CTO2. We tried 2 different CTO balloons of 0.5, 0.75. We tried all the balloons on our shelf. Nothing worked. Any ideas? So we used a tornus. And the tornus went through. And the tornus 2.6 crossed. It was, unfortunately, the last tornus in India. It happened to me in my cath lab, and we were lucky to be able to get that tornus in, because the tornus is a tremendous device for this purpose. And once I had the tornus in, you can see that I got my rotawire in. And with the rotawire in, I went and did a rotational atherectomy. Now halt over here. Before I do a rotational atherectomy, can you note a little bit of staining already that is happening there? So before I started the rotoblader, with the tornus, there was some flow in that artery, and I could see that I had started staining a little bit around. So I knew that I am on the verge of a disaster, but the only way that I can sort it out is if I have luminal access into the artery. So we did a rotational atherectomy, and post-rotational atherectomy, I was in the True Lumen. You can see that. We went in and dilated with cutting balloons, and you can see my perforation there. Can you see that perforation closing up? Now the problem is, the minute I open up the proximal LED and the flow increases, this perforation is going to get worse off. And here is where I want to make a comment. You know, we said wire perforations are not wire perforations. This is a wire-induced perforation which has gotten worse with subsequent devices. So here we have this perforation. So I went and quickly put in a stent. The decision we need to make is between ischemia and tamponade and hemodynamic stability. So if ischemia is a problem, sometimes fix ischemia first. Or if you have hemodynamic stability, get the arteries go flowing, and then you can fix things. So here I've got my stent in there. And once I've got my stent in there, we had the diagonal. So we cut the diagonal and put a DB and got the diagonal out of the way. And then we put in our left main to LED stent. And we did a very quick IVUS, optimized it, and got that going. And once we did that, we had time now to put in a pericardiocentesis and stabilize her. So we stabilized, put in a pericardiocentesis, came back, and then identified where that block was. Can you see that perforation over there? And then put in a guidezilla into it, threaded our graft master there, and then sealed it, and this was our final result. She went home on day 5. She did well. But sometimes when you take on these challenges, be prepared, and be prepared that you have some help in the cath lab. Make sure that you have material in the cath lab, and that a calcified lesion cannot be done with just a rotablator. There are multiple layers of tools and protections that you need before getting into the cath lab, and make sure that you are prepared for the worst scenario. Discharge and doing well. This is a calcified lady, an elderly lady again. Stop me wherever you need to work. And this is a calcified lady, LED with a diagonal. We did a rotational atherectomy to that. And then we did a rota to the diagonal branch as well, because that was also a problem. So post-rota diagonal and LED, you can see that it's a good flow. Now my question is, the rota wire is in the diagonal branch. I want to put a run-through wire in the LED and a run-through wire in the diagonal. So that's what I did. And only thing I didn't realize is I've gone into a small little branch of the diagonal rather than the diagonal. And at this point in time, though she's complaining of chest pain, I'm not thinking aloud because I'm not concentrating. But if you concentrate and look hard enough, this picture is telling you 1,000 things. And then I realized that when I put it out, I can see that the wire perforated that nastily the diagonal post-rota. So this was not a rota-related complication. This was a wire-related complication, and wire-related complications cannot be innocuous. They are deadly. So what did I do? I went back into that branch and put in a coil, thinking if I put in a coil, I'll stop it. So we put in a coil, it reduced the flow, but it did not seal the perforation. So I went in there, and with a guidezilla, we put in a covered stent there. Once we did a covered stent, we went in and completed the LED angioplasty, did a pericardiocentesis, stabilized her. So the lesson is that if you have done a complex rota, sometimes don't think that you're just going to put your run-through wires in parallelly. You already have a microcatheter on table. Use your microcatheter to get your wires in place and exchange them rather than doing it blindly. Sometimes once you've done a procedure, you have delicately changed the surface of the plaque, and then wires may go subintimal and go even outside in small branches and cause trouble. So I think that is the lesson that I took home from here. I think we got complacent with rewiring the artery and paid the price. So here is when you do complex cases, you become overconfident a little bit, and don't let overconfidence ride you. And after so many years in the cath lab, I still sometimes slap myself and say, sorry, Kirti, come back to reality. Anything can hit you. The coronaries are very nasty. They can humble any one of us at any time. This is an artery that was attempted by a very close friend in Delhi. And he said, Kirti, I'm sending you this patient. I tried it. I couldn't do it. Can you do it? So this was the TIC International Conference where we did this as a live case. There was an RCA which was totally occluded. So we did a laser to that with a rota, completed the RCA. And then our job was to do this calcified circumflex artery. And so when we did this calcified circumflex artery, we were doing a rotablator. And when we did the rotablator at 200,000, you can see my rotablator goes in there, and I have a burr which is stalled and stuck. Now this patient is getting ischemic. Thankfully, I had opened the right coronary artery, so it wasn't so impactful. And when I did that, I went in to see if I could cut the shaft, put in a guidezilla, and see if I can implant. Nothing. It wouldn't come out. It was stuck like cement. So you have to think very quickly in this. And what I did is a microcatheter, and I took a UB3 wire, and you take a UB3 wire, and once you're there, you loop the wire, and you then do what you classically call as subintimal tracking. But that went into the OM branch. And once you go into the OM branch like that, you can then take a balloon on this and you nudge. The balloon is basically to shift the rotablator from the plaque into the lumen again. And once you do that, the rotablator just comes out without an issue. You've established flow. Now you're okay. In this whole bargain, there was a wire here. So I caused a wire perforation into the distal circumflex, you can see. So I put in a coil and sorted that out, and then established flow. And we put a stent right into the descent. I was guided, put in a stent all the way back, and he's doing well, thankfully. So getting into trouble is possible with no exceptions. Keep calm, use all your skills, and try to get out of that situation if you can. There are two ways rotablator gets stuck. One is what I showed you, it gets stalled. The other is it can get stalled as in terms of what happens is it goes, this is a case that was done by colleagues, and they did a balloon dilation but couldn't get any stent inside. That was the final result, unstable angina. So 4 days later, we went in with a rotablator and we tried to do this. And lo and behold, when the rotablator went into the mid-segment, Kokai's effect, it wouldn't come out. But this is interesting because my rotablator could be activated and go distally, but it would not come back beyond this one point. So when that happens, take your rotablator and go distally and park it a little distally. Don't park it in the lesion where it's getting stuck. Go down, because if you park it in that, your guide catheter will get sucked in and you'll get ischemic. So once you take it forward, you know that you're okay. And all you need to do in this, what we did, what should we do? All we do is, this is the mechanism. So there's an eccentric plaque, you have a wire, and when you do a rotablator, you create a soft corner, and because it's a low, that wire cuts into it, and when the wire cuts into the plaque, now you have a rotablator doesn't come back. So if you put a parallel wire inside and occupy that lesion, it then pushes the burr outside, and it simply takes that burr out. And that is what we did. We put in a parallel wire. This is like a simple normal wire. And then roll the burr, and the burr just comes out, and then complete the case and stent it. So I think those are the two tricks that one should learn. Of course, this is in the Bridge County Hospital cath lab for this mid-LAD lesion. I got called in because while doing a rotoblader, one of our operators got a stuck burr in this 1.25 burr. And you can see the guide catheter backing off. The burr is now stuck. Now, the burr is stuck, and when you want to do this, the guiding catheter going over there, very difficult. Don't do that. Don't let your guiding catheter, don't make this mistake, because it will tear the whole proximal artery, and then you make yourself more trouble. So take your time, cut the shaft, put a guide extension. That's an easier thing to do. So anyway, we got the guide extension in, and we got the burr out. But once we do that, this is the lesion left. So we went in and did a 1.5 burr. I did a rotoblader with a 1.5 burr, got it right. And then, of course, with IVUS, we realized that the dissection was all the way to the ostium of the LAD, so we stented it and got him out. We've had these perforations, like contained perforations, when we've had stuck burrs, and this is from my past. This is a case from Selfie when we did it. And you can see the proximal dissections that we need to look at. And when you get a burr out like that, sometimes it has done an atherectomy. It has actually taken a part of the tissue out. Can you see that? Tissue hanging on the burr. So this is crazy. But these are photographs worth a million, really. In this bifurcation lesion, elderly man, very calcified, and we did an LAD rota, we did a diagonal rota, and when the diagonal rota, hand on the chest, that's a sign of complication. When somebody talks about chest pain, hand on chest during a rota, think big. Always a big problem. This is the big problem. And this big problem, I had a tremendous anesthetist in my cath lab, Sharmila, who really bailed me out with this, intubated, everything done. And then what we did was, we had ischemia and that, so we went in. I wasn't sure where the perf was. I couldn't tell at this time. So when you don't know, don't panic. First, dilate. We did a culotte, quickly got a culotte going in and got ischemia out of the way. There's a little bit of edge dissection. We completed that at the end. And with that, look at this angio. Looks great, right? But don't be fooled. This is not great, because right now you need to look at hemodynamics. And when you look at hemodynamics, we started at the perf, you can see, and present the heart rate is 90, the blood pressure is even lower. Think of pericardium over here. So when we do a pericardiocentesis, we realize that now the leak has started appearing again. Can you see the leak coming from the diagonal? Now the location is clear. So the pericardiocentesis relieves the tamponade, it allows the leak to reappear, and it tells you where to seal. So you take a 3O balloon, you dilate, put your guidezilla all the way when you've done bifurcation lesions, and through that you thread your graft master. You can actually position it in such a way that you don't cover the bifurcation, you don't come into the carina, and then this is done. He's done well. This patient lived, he was 85, he lived till 93 when he died of renal cell carcinoma. And what is the worst part is he was my maternal uncle. So you can see the stress with that, yeah? Crazy. Last, okay. So, calcified torches, if I have last, then I want to show you, I think you'll want to see what happens with laser, right? Yeah? Okay. So we've been using laser now. We've got more than 200 cases on. We published heavily on it as well. But so this is a case that was sent to me by Jamshed Dalal from there. They've done multiple PCIs. The circumflex is really tight, and this is an ISR. And when I did this ISR, we used a laser to break and expand the unexpanded stent. And when we did that, you can see that very soon we actually lost flow into that OM branch. And what had happened is we had caused an intramural hematoma at the mouth. So when we saw something like that, we put wires in both the arteries. We did cutting balloon dilatations. And what we did was we opened the intramural hematoma into the true lumen and allowed it to heal. We put in a drug-eluting balloon there. And we have a CT now, which is around 6 years down, which shows a perfectly patent artery into both. This was a very calcified left main dilatation, but along with thrombus, came with acute coronary syndrome. This is a patient with ILD, on oxygen, ambulatory oxygen, extremely critical. My question was, how do I deal with this very calcified lesion? We had multiple options, but all options were technical complications of slow flow and difficult to cross. So we had lasers, so we used a laser here, the LAD, and then with an impella support, we used a laser for the circumflex. But when you use laser in bend arteries where there's a large branch, and if it doesn't go and we use a little bit of blood or a little bit of contrast, the atmospheric pressure is high. And in this patient, you can see, look at the OM. The OM1 over here is okay, and there, can you see the dissection? So side branches can get compromised when you use such acoustic pressures. So the lesson learned from this is, if I'm going to do a laser with contrast across a large branch, protect the branch, even if the branch looks normal. So even if the branch has no disease, if you're going to do a laser with contrast, protect the branch, because you can develop, it can disrupt intima, and it can cause an intramural hematoma, and you lose true lumen. The other is this ISR CTO that we were doing. And when we do laser with contrast now, we've got more than 100 ISR cases with laser. You can see that our first pass with saline is good. We've established flow, so he's stable. And once he's now, we want to do laser with contrast. We did a total of 3 runs. And laser, can you see those air bubbles going in there? Those are not air bubbles. They are called cavitations. This is a common phenomena with contrast lasing. It works by molecular bonding break. It works by sonic waves, like a ripple. You throw a stone in water and you get a ripple. That's a sonic wave. And this is a cavitation. So vacuole cavitations happen in contrast, which look like air bubbles. This is not, don't be worried. Contrast laser is working, that means. And when we did run 3, you can see what happens with run 3. Watch it carefully. We go, and as we contrast, you can see extravasation of contrast outside the stent. Can you see that? This is 120 atmospheres pressure, and it disrupts tissue. So when you see that, you stop lasing. You know you've done enough tissue fulguration inside. You come back. It doesn't cause, this is a contained hematoma, which is not a problem at all. Stent, and you're out. So I am going to stop here and say that you should only think of all this as very humbling moments, and we should put our feet back on our ground and try not to get too overconfident, and make sure that we respect the coronaries as we go forward. Thank you.
Thank you for those very exotic cases, and we know that when you do such challenging cases, we do it for some reason. Obviously, it's not that, when all the other options are exhausted, then you take these patients and you explain them properly. But for most of us, taking consents is really like, okay, either sign karo, this is a high-risk consent form, this is a regular risk consent form. I know that you spend a lot of time in taking consents. If you could just tell us a little bit about that, it will help.
So, we spend an hour talking to these patients maybe sometimes, and I talk to my patients in a complex PCI, which has come in. I talk everything from what is the risk of death, what is the risk of a complication, what is the risk of me perforating that artery, what are the choices I have, and everything. Because you don't know which one. And there are 1 or 2 patients who will say, oh God, this is sounding too risky, and they'll go away from your office not wanting to do the procedure. So be it. But it is very important to spend an entire time and take a consent drawn which is specific to that patient and that particular lesion. Because generic consent forms that we sign, I have no validation in court. 2, there was, when I was in Bombay Hospital, we'd done this, and I had somebody who sent me a legal notice for a complication. And the legal complication said that we were not explained that this could happen. The patient didn't die. We did an angioplasty, and then during the angioplasty something went wrong, and our surgeon went in and sealed a hole somewhere, which was a pericardial space and things like that. And he did well, but he sued us because his bills went up, and he said this is our doctor's negligence. What saved me was the fact that I had taken a consent, and there was a doctor involved in US who was also talking about it, and I'd sent an email saying to him that we are doing a complex procedure, and these complex procedures have a risk of perforation. Sometimes they're dealt with in the cath lab, sometimes you need a surgeon's hand, you can have death on table, you can have this on table. So the legal team said, if you've sent this email, the case is shut, so we just send them that if you don't withdraw the case, we'll take you and we'll charge you for defamation. They withdrew the case. But what saved me was the fact that I sent an email out to not only the doctor in the US, but all the next of kin. So if you have, one of the biggest problem is when they actually come in for the procedure, there's one person who'll show his face. But when a complication happens, 5 different people come over there. So you need to talk of who is next of kin, take all their emails, my secretary takes all their emails, and an email is sent out to not only them, but also to the referral physician. I mean, Milind spent some time with me in the cath lab, and there are times when Milind had a case, we've sent those out to Milind as well, and said, Milind, this is the risk factor document that even you need to know. So I think the more we do is less. That's a very good question. We need to video record the consent also by law, but if you send an email out to next of kin and give them an opportunity to revert back to you, I think that should be plenty.
What we have is, we have the CCTV with the sound, and what we talk to the relatives is recorded.
So I think that you need to not only record it, you can make a speechify, take all the record and make it a document, and then legally sign that document out saying that and put it in your file. Not only that, you should not put it to your file only, you should also send it to your medical director and your CEO that you've taken this consent.
Kirti, fantastic cases. The first case, or rather the case where you used the tornus, you had used already a laser. Why do you feel the laser, the uncrossability? That is one of the indications for laser, I guess.
So while laser is a great technique for uncrossability, when you have serial lesions, laser works by many mechanisms, right? And when you have a tight lesion proximally, and then you have a distal tight lesion, calcified lesion, for laser to work, it has to reach. And sometimes laser works on the proximal lesion by not crossing it, but modifying it. But to go to the second lesion, I would have had to dilate this whole thing, but I had to do a rotoblator. It wasn't yielding to balloon dilatation. So once I did a rotoblator, I didn't need it again. Otherwise, I have cases where we've done rotoblator, we've done all that, and then come back and done a laser because now the laser has gone closer and done it. But when you have serial lesions, for laser to work, you have to get the laser close to the cap. I wasn't able to do that.
Another question. Recently, I had a ISR CTO, and we used the laser, but it didn't do that well because there was calcification when we did the imaging. When you have a ISR, calcific ISR, what is your experience?
We only have calcific ISRs in CTOs with ISRs, and we have almost 90% incidence of calcium in these arteries. And so there, laser works with contrast. I don't know if you use contrast, but the contrast, the way I showed it, that's how you use it, and that's how it works. I mean, I can't make a comment based on a generalized kind of statement, but if you showed me a specific case, I could tell you.
But in this case, does it mean you require more additional tools? I used an IVL, then it worked well.
You always need a guide extension catheter which goes close so that your irrigation is, the laser catheter being here, the medium has to be beyond it. So if there's contrast beyond it, it'll work like a contrast. But if you cannot get contrast to beyond the lesion, beyond the laser catheter, it's not going to work.
So the last question, after this, when you have done an imaging, after you've done the contrast lasing, what do you see?
We see disruption. So when I see calcified lesion, I see a lot of disruption. That's not a part of my talk, so I didn't show you that. But maybe one day we could have a meeting where when you do laser, you see fractured calcium. You see fractured calcium, you see fulguration, you see soft tissue vacuolations. So you see a lot on those images, which actually, I wish I could show you images, but too short a time.
So just one question. You showed this case where you did a contrast lasing and there was a stent. So do you do contrast lasing only when there is a stent and not in a native vessel?
So contrast lasing is off-label at this present time. though I am saying I do it, it's not something that the company recommends. We have put in a huge paper which is accepted in JCC Interventions, which is a task force paper which I'm a part of. You'll see it in the next 3 months, where we've recommended it with some little guidelines. But in my ISR cases, we 100% do contrast glazing now. Without doing contrast glazing, ISR does not work. You cannot expand those stents as much as you would like them to be expanded. So, but this is the worst case scenario I've shown you, that this can happen. I mean, the worst case I've not even met yet. Who knows, something worse could happen in another case. But you got to be thinking. So when I do contrast lasing, say I do normal lasing at 80 fluency, then when I do contrast lasing in a sensitive artery like this, I would come down to 60 so that I deliver less energy as much as I can, because when you do such repetitions at 80 with contrast, the bubbles and vacuolation are aggressive and very aggressive.
So in the absence of a stent, would you do contrast lasing?
The question should have been, have I done? Yeah, so have I done contrast lasing? Yes. I have done contrast lasing. Again, that's another part of this talk, so one day I could talk about it, but especially for uncrossable lesions, for calcified lesions, for unexpanded lesions, I've used it, and it has worked brilliantly.
So, last comment from Dr. Poddar, and then we'll...
Wire-related perforations are dangerous in the sense they are more subtle. And many times when you leave the cath lab, they manifest, and then the pericardial tamponade occurs and you are not there. So that's the worst part of wire-related.
Those are the slow perforations where
slow
the
perforations, and
these are nasty ones,
And one thing I wanted to ask: have you seen pseudoaneurysms after laser?
So I have seen. That's a great question. So we've done a young gynecologist who had a CTO of the mid-LAD. And the CTO starts after the second diagonal branch, and it's a 40 millimeter CTO segment, and then 60 millimeters of segment of disease. So we did a lasing. It was an uncrossable lesion, so we did a lasing, and then we did a cutting balloon. And then when we did a cutting balloon, we did a cutting balloon to the IVUS guided, and we did it at 16 to 18 atmospheres, put in 2 drug-eluting balloons, and we got a CT done at 1 year, which shows a perfectly normal artery. He recently had hyponatremia, so we got him in and we sorted him out. He had an angio done. So the LAD is absolutely patent. There's a little bit of aneurysmal-like which is there now, but we're going to look at CT and see 2 years later whether that's a growing aneurysm or it's a stable aneurysm. But his bigger problem is LDL. He did not take his statins with this entire thing, and his proximal LAD left main lesion, which was 30%, has now become 50. So we put him on.
Yeah, Kirti, the last one from Dr.
It's not
Loya.
a question.
Yeah.
It's a request.
What is that?
From the house. Kirti has a very well legally drafted consent,
okay.
One sample, Kirti, if you can share for all of us. Really. We can work on those lines.
I request you, thank you so much for showing us all your complex cases, including fatality. That takes real courage. And I know that you are an extremely good operator, so thank you so much. I also want to thank Gaurav, because we could not have any discussion on his cases. They were also excellent. And I would request both of you to be available so that a lot of people have questions maybe. But because of a shortage of time, we can't take on those questions. Thank you so much again.
Thanks a lot.
Yeah, so we call it, close this session and go to the next one.
I think the next session, the chairpersons would be Dr. V.T. Shah, Dr. Brajesh Kaur, and the moderators would be Rajiv Sharma, Sheikh, Pagari. Can we have the next speaker, Saurabh Limay?
So I will be presenting a series of complications on a balloon and stent retrieval, all from Sion Hospital. I thank my mentors for giving this opportunity to present. We begin with a first case. This is a 57-year-old gentleman who presented with anterior wall MI and was lysed with streptokinase. His echo showed severely compromised LV systolic function with ejection fraction of 22%. Angiography revealed severe osteoproximal LAD stenosis. The lesion was prepared with balloon pre-dilatation, and a 3 by 38 mm drug-eluting stent was deployed from LAD ostium to mid-LAD, followed by post-dilatation. We noticed sudden drop in deflator pressure at this point. As we attempted to withdraw the balloon, the shaft came out unusually easily. However, the fluoroscopy showed that balloon itself remained within the coronary artery. This suggested balloon shaft fracture, most likely at the junction between hypotube and the balloon shaft. Fortunately, the fractured proximal part of the shaft was still within the guiding catheter. So we advanced a second balloon into the guiding catheter and inflated, trapping the fractured shaft against the inner wall of the guide. The entire assembly was then withdrawn together successfully, retrieving the retained balloon in one piece. The entire assembly, including the guide, fractured balloon, and the inflated trap balloon, was successfully withdrawn from the femoral axis. Procedure was then resumed. A new non-compliant balloon was used to complete post-dilatation of the LAD stent. Final angiography demonstrated optimal stent expansion with TIMI3 flow, and procedure was completed without any other complication. This animation demonstrates, so there are two more cases. This animation demonstrates tap balloon technique that we used in this case. This is applicable only when the fractured balloon shaft is still within the guiding catheter. A second balloon is advanced parallel to the fractured balloon, positioned within the guiding catheter. The balloon is then inflated, which traps the broken balloon inside the guiding catheter. A stable grip is achieved and the entire assembly is withdrawn. Let's move to the second case. This is a 54-year-old woman with diabetes hypertension who presented with NSTEMI, had a preserved systolic function, and there were ECG changes in inferior lead. Patient had triple vessel disease, and after heart-team discussion, she opted for PCI. This was her baseline angiogram. There was disease in the proximal LAD, a disease in obtuse marginal. The RCA was diffusely diseased from proximal to mid part with total occlusion in the mid RCA. We planned stage PCI beginning with culprit vessel, which was RCA. We proceeded with PCI to RCA. The lesion was crossed with Fielder FC and prepared with balloon dilatation. A 3 by 48 mm drug-eluting stent was deployed from RC ostium to mid RCA, followed by high pressure post dilatation. The angiogram here showed a significant residual stenosis in mid RCA. Unfortunately, that video is not with us. We decided to treat the lesion with another stent 2.75 by 33. However, while advancing the second stent, we encountered significant resistance at proximal stented segment. And despite multiple attempts, the stent could not be advanced smoothly. While attempting to advance the second stent, the stent became dismounted or deglowed from its delivery balloon. Meanwhile, unfortunately, the guiding catheter also got disengaged, and the undeployed stent remained threaded over the guide wire, which is seen dangling in the aorta, creating now risk of stent loss and systemic embolization. So we obtained a contralateral femoral access and introduced a second 7 French guiding catheter. Through this, a gooseneck snare was advanced into the ascending aorta. The displaced stent was carefully snared and prevented further migration. After successful retrieval, we completed the planned PCI with a new drug-eluting stent, and 2-month follow-up angiogram also showed widely patent RCA. Coming to the third case. So let's move to our third and final case. A 59-year-old gentleman with diabetes, hypertension, and STEMI had preserved a systolic function, EF of 60%. Angiography showed single vessel coronary artery disease involving RCA. There was long disease segment in the proximal RCA, and there is stenosis in the distal RCA as well. Lesion was prepared with balloon dilatation, and we planned to implant a 2.75 by 33 mm drug-eluting stent. However, while advancing the stent, we encountered resistance, most likely due to underlying calcification, and here the stent became demounted or deglowed from the delivery balloon and remained in the RCA. Our first strategy was retrieval, as it still had the wire access. We initially attempted retrieval with using a micro snare. However, after multiple attempts of using micro snare, the stent could not be retrieved. and we need to have another solution. Unfortunately, while removing the micro snare, the patient coughed, and the guide wire access as well as the guide got disengaged. The now undeployed stent was left behind without a wire access through it, unlike the second case. We had no two options. One was to crush the stent in the proximal RCA, but that would have given more metal. The other option, which was difficult, was to pass a wire through the lumen of undeployed stent and deploy it gradually. So we initially tried to go for the second option. After multiple attempts, a wire could be passed. Sir passed the wire run through NS through the undeployed stent, and it was sequentially dilated to its intended dimension, deploying the stent in the proximal RCA. So we completed the procedure by implanting another stent in the mid RCA with adequate overlap, post dilatation done, and final angiography achieved TIMI-3 result. Before concluding, I will have some review of literature on stent loss. The first question is, where is the lost stent? If the stent is embolized outside the coronary circulation, then we need to assess if retrieval is at all needed. If it is in some peripheral bed and without any ischemia, it can be left alone. However, once it is an inside coronary, the next question is if the wire position is maintained. If the wire position is maintained, we can advance a small balloon beyond that stent, inflate it, and pull the stent back if it is possible. We can use snares as we attempted in the third case. Medtronic has gooseneck snares available from 2 to 4 mm size for coronaries to large for larger arteries, and N snare is a 3-loop snare which also is available for coronaries. Then the third technique is wire intertwining, where another wire is passed and these two wires are twisted simultaneously, so to entangle the lost hardware, which is pulled back again. And if everything is failed, we have to call for surgeon's help. If the wire position is not maintained, then it is option to crush the stent with another stent or to deploy as we did in our third case. And about balloon retrieval, there are 3 main scenarios. The balloon could be failed to deflate, entrapment of the balloon, or balloon shaft fracture, as was there in first case. So the next question is the fragment of the broken balloon still inside the guide? If yes, a simple trapping balloon technique can be used. If not, snare can be used. If the balloon is failed to deflate, then we can use another indeflator, attempt withdrawal without deflation if the balloon is small. It can be inflated till it ruptures, and it can be ruptured with a guide wire as reported in this case report. They had this trap balloon which was not deflated, and they used back end of the guide wire to rupture the balloon to successfully retrieve it. And the third scenario is balloon entrapment, where if the balloon is deflated, we can remove it by back and forth movement. We can use balloon trapping, advance a guide extension, use a snare, or a call for surgeon's help. Rather than ending with my own conclusions, I would like to end with few words about today's topic by Professor Colombo. He had put his slide about complications, and I don't think I can summarize the subject any better than he has. These are limitless lessons that interventional cardiologists can continue to learn from. He ends saying that after a long interval without complications, be ready, one will come. Thank you.
Saurabh, I want to ask one question. I want to ask.
Yes. What he emphasized, actually, this slide he had shown in his talk when he was awarded the Lifetime Achievement Award in India Live. So that time he said it is the second step or the second complication which is more dangerous than the first one when you try to solve the first complication. So that is what he emphasized. So in that panic, don't create another complication which will be more catastrophic than the first one.
I want to ask you.
Okay.
Sir, that's why I say always more than one operator in the next level.
Yeah.
That's my observation.
Sure.
Saurabh, that stent is dislodged with on the wire. The retrieval through the snares is the same guide
No, sir.
But
we
you used a different
contralateral
guide.
access and second guide was used.
How did you remove that? It formed a U loop. No, how did you remove that? You cut
Through
the
the second guide, sir.
How? How did you remove that one? Because your wire and stent is in the one guide, and the second guide you use it to capture the
it
distal
was
wire.
not. It was hanging in the aorta.
Correct.
So therefore, we took a contralateral femoral access. We passed a guide catheter through it.
You
We passed a
captured the
snare
wire,
through it.
distal wire?
Yeah, and we just took it out.
No, two guides are there. How did you remove it?
And already it is.
This question is what happened to the first one, correct?
First one. What happened to the first one?
The first one was removed.
Already it is there in the radial. Na? It is connected to the radial.
Yeah, so that could be removed. No, once we snared the stent, that was not a problem.
You are what?
No.
You can show it. No, your out and stand is hanging.
No, I didn't get the question.
Did you remove the whole assembly in short?
There is a loop of wire, one in the radial, one end of it in the radial, the one end of it is in the femoral. They are asking you, how did you tackle that loop now? Yeah, that is what probably. So now you are holding the wire from the femoral part through a snare. Then you pull out all the wire, the radial wire, you left the radial wire because this wire was coming from the radial side. Na?
No, and the wire access is lost. So with the wire it is all removed. That's
bilateral femoral.
Bilateral femoral.
correct. No, that's correct. You have removed. See, what he was asking is, did you maintain that wire position when you were snaring this out? That is what his question. No.
Did you pull out the wire also along with the stent? Whole of the wire was pulled out from the other side.
Together, you can't snare it in the other guide catheter.
One of the principles of snaring, it is easiest to snare if you have wire access. Then you can pass the snare over the second one if you are from the same route. Otherwise, you just hold both together and pull them out.
Pull it out. Yeah.
Both together. Actually, the most difficult case was just a quick comment, the third case, because the stent had got degloved and the access is lost. Now the problem is everybody was telling me ki just crush it to one side, you will not be able to wire it. Now I don't like to crush such a long stent in the RCA and leave a big metal load. I said let me try for 5-10 minutes, let me try and wire through the lumen of the deformed stent. I think that day we were lucky we could wire
it was in the
No, but the most important thing, Milind,
the proximal part of RCA.
Milind, if you have to cross a wire like this, first of all, we should confirm with imaging before you put a second stent over it, because if the wire goes in and out in one of the struts, you are done with it. One.
I agree.
Secondly, when you go like this, you go with a loop, always. See, this situation arises.
No, it was not going with a loop. We had to. The stent is under expanded. The stent is undeployed. We instead, what we did is we used a taper tip wire, and that is what went. We used an XTA.
The other way.
1 minute, I'll tell you how we confirmed it. An imaging catheter through the undeployed stent would have been difficult. So what we did is we used a very small balloon and we took a stent boost in various projections.
In various.
And we saw through that.
Yeah.
That is what.
Sir, it was hanging in the Ashtamoda RCA. You should have tried the retrieval, na?
So what happened is he has shown it. Retrieval was tried, but the snare could not get past. See, problem with retrieval comes
Entangle. It was entangled in the RCA stent.
The stent couldn't. See, what happens sometimes is best thing to do is to cross distally, wire and take out the snare. Proximally, often there is not enough space to snare it, and even if you engage with the snare is not able to pull it out. And if you pull too hard, you will avulse the artery. So you have to be very careful, and once access is lost, you are in a big soup. As long as you have access, you can load the snare over that same wire. In this case, the access was lost. Then it becomes tough.
While wiring, if it could have been dislodged to distal part or embolized, there could have been disaster, na?
While wiring?
We are taking the wire through the stent, na? So if something wrong happen, it can go.
What choice did we have? What choice did we have? This is the last resort.
Yeah. No, but anyway, Milind, that was good. You were lucky that day that you went through the tournament. Come now, Shishir, your turn.
See, I think the shortcuts creates more complications. And using a good guide is selecting a good guide, dilating it well, and then using something like a buddy wire, then using a support wire, using a guidezilla probably will prevent all these complications.
No. First of all, degloving was a very common complication in earlier stent era when the balloon and the stent were not. Nowadays, it's not so common, but even then it can occur, especially in calcified lesions.
Dr. Milind, were there stents of reputed companies?
So that's what I'm coming to see. now with all stents being available and of the same price, in between we had problems with a certain lot of stents. I'm not going to mention the name in this forum. And then once we stopped using those stents, this complication gradually, but it can still happen. And I think, as Sir said, bed preparation is also very important, and it can still happen.
It can still happen with the best stents. But though it's not so common. Otherwise, in the initial days of stent, every forum of complication would have deglobing, especially at the ostium of RCA or at the left main. Anyway, come on, Shishir.
Good afternoon, sir. I'm thankful to CSI organizer, that is Kane sir and Milin sir. I will go with when guide is misguided. Okay. That means something I misguided my guide. Okay. 62 female, diabetic, hypertensive, presented to me with NSTEMI, tropi positive, and EF 40%. So you can see the angio. So short left main, definitely. The circ 80-90% looks like to proximal, and LED is 80-90%. And there is a big tortuosity in the mid of the LED. And you can see RCA, RCA, there is a ostial RCA. You can see in the right side, okay. Ostial RCA 90%. So I'm dealing, I thought let me have an option of CBG. So I'm dealing triple vessel, LED 90, circ 90, RCA ostial 90%, and plan was CBG. But there's a relative, they thought go for PCI. But however, one of our son is a lawyer, he thought he was on the way, so he asked me to take some, he will come. So I thought something wrong is going to happen to me because the lawyer is coming. So after some time I waited, now there is radial spasm, I went to femoral, then something wrong happened now. So I took EBU 3.5, 7 French, but by the time I did something wrong and I was not able to engage, so I thought let me use jail. So patient developed severe chest pain, hypertension, BP went to 50. So you can see something wrong, something hanging in the, there is a dissection exactly. So where is the dissection now? So short angio shoot, there is a dissection in the circ, and I am not able to take my wire in the LED properly. So where does it started? So definitely something wrong in the left main, but first time I felt, so the tight coronary is sometimes good for all. That means the dissection has happened in the left main and gone to the circ, but stuck and the stayed at the exactly where the 90% lesion did. So I thought let me do something to circ. At that point of time I thought, should I put stent from the left main to circ? At the same time I thought if something wrong happened to, if I put a stent in the left main to circ, I may not now cross the LED. So I thought and the left main is short. So let me fix ostial left main, ostial circ to the proximal. But my at that point time patient has CPR also. So in advantage I took a short stent. I could not exactly reach at the target side, but I deployed that. But still patient had pain, persisting pain. So I thought, okay, now something wrong in the LED. So I went to the LED, did some pre-dilatation. I established some flow in the LED, but patient now develops CPR. You can see CPR is going on. So something wrong. So left side you can see the CPR is going on. So, and you can see in the LED my wire is just not in the proper, the LED wire is not in the true vessel. So at that point of time, so I thought no, I should do some pre-dilatation. LED. So 2.2, I think 2 mm balloon I took, I made pre-dilatation done. And now, what is happening? Hanging, it is, I think some lagging is going on.
Just a minute.
Now we can see the IBP.
Yeah, sir. So
When was that?
I started IVP, sir. I took IVP.
Yeah, but now. Afterwards.
Always, I thought IVP is not my first choice. Always, I have to establish the flow. IVP does not work if there no coronary flow is there, sir. So I have to have some.
This side, sir.
Run करो. Okay. Okay, I did some pre-dilatation to the LED, mid of the LED. It looks, so now it is more complicated than doing angiography.
Shishir, I think by the time you can continue talking to us, what exactly were there in your mind?
I have to show now. How can I talk?
Yeah, I mean,
Sir, I have to show that, sir.
no, I mean,
Sir, what happened?
I mean, what was the thought process? I mean, you have gone into the false lumen of the circ, the LED.
This one.
Short circuiting not allowed.
Okay, I think it is enough. Okay, by the time you can see the ostial LED now got some dissection. So I thought I have to do something to the left main. So LED ostium got dissected now. So no, not a single slide is moving, sir.
No, go to the next slide. Don't get stuck over here.
No, next slide.
No, I'm telling this fellow.
Sir, next slide is not moving also.
That is also not moving.
This is.
स्लाइड है
इसमें नहीं है, इसमें डालो.
I must say, it takes a lot of courage to present a case like this. I mean, it's a big courage, you know.
No, sir,
It requires a lot of humility to present complication cases, first of all. That's the most important thing. Right or not? Yeah.
Shishir, did you realize where you went wrong? The first wiring itself was wrong? You feel you went into a false lumen?
My first slide, I misguided the guide. So it was the guide.
Was it the first time when you were engaging, your guide dissected the left main?
I think if he can play slides, we'll let him complete.
Yes,
बेचारा बीच में ही.
वही ना.
Again, computer misguiding.
Most important in this case was the son was a lawyer actually.
Yeah.
You don't know he was coming or you anticipated some.
You have rewired now.
Okay, now the CPR is going on. LED ostium, you can see there's a critical now, it is fully compromised. So now pre-dilatation in the LED. So now I took the no sir. So I took the IVP, you can see, then BP again, okay. Okay, now I thought let me do justice to the SORC, which was initially was a tight lesion where the dissection was stuck. So then I did 3.5 DS there. Then I came to LED. repeat, I did the stenting from the ostial circ. So now I did the pre-dilatation in the LED, 3 balloon, then you can see the left main dissection, ostial left main dissection. So I thought now this right time to do the ongoing CPR, I took the left main to LED, I did the stenting. So exactly, if somebody will ask what the technique you did now, whether it is a V stenting, whether it is a mini crust stenting, so at that point of time, I didn't think I have to put a stent, I thought. So exactly I did the ostial left main to the LED. So as I repeat, it's a very short left main, so that nothing.
Left main to LED was 3 millimeter.
Next is not running, sir.
First of all, ostial circ तक आना ही
अरे यार सोड़े आप ऐसे करते हैं क्या कोई इतनी बड़ी मीटिंग में नहीं वो लास्ट में अरे सब Okay, so I did the ostial left main to LED stenting, and luckily everything is fine. So no, this is yet to come. So patient stable. So after 2 to 3 days, after next day I just removed the IVP. Patient got okay. Then. So after 3 weeks, this is the good thing when you do justice irrespective of a complication, that lawyer brought her mother again, okay doctor, you did the complication, but I'm happy, my mother is happy now. Now after 3 weeks, I checked the flowing, even if I didn't think I will go recross, I will do creasing, nothing. Now I did justice to the RCA, you can see ostial, I did cutting balloon, I put a stent, I came out. So cutting balloon, and so this is the, I think, okay. So this is second case, again similar, 79. It's just, sir, this is due to.
I agree with you, but we really are in a.
Okay, thank you.
Shishir, if it is working, show the complication.
Okay.
Don't show the solution.
No.
We know the solution by now.
Sir, this is, okay, sir. Okay.
It's finished.
Okay, there are some, this angio was done in the Orchid Hospital. They referred us here. So you can see triple vessel disease. I went, there was something, so RCA engaged their problem. I did also problem. I thought, let me do plastic with RCA before I touching the left main, but unluckily I was not engaging the RCA, so I failed to. So I thought no, do the justice. You can see I took the 3.5 femoral approach, then the complication started out. You can see there is a dissection, and you can understand still picture. You can see the ostium of the circ, ostium of the LED, everything got stuck. Then with such CPR, blindly I waited, and I didn't think where is my wire. And second, I took the 3.516, and from the ostial of the left main, I did the diploid. I stand the diploid.
Right. So, Shishir, we end here.
Okay.
The moral of the story
So
is...
finally, sir, LED circ was stented.
Correct.
Okay.
Very good.
Thank you. Thank you, sir.
Finally, the first case stenting technique is what is that called?
Sir, actually,
No, forget about that. He said that. I don't know what technique. No.
sir, retrospectively go, it will be a mini cross only.
He said,
but I did not do kissing. I just put the stent
Shishir,
on.
don't discuss that.
No, sir,
Discuss the reason of complication. The reason of the complication, as you said, it is a misguide. But more important is, if you take shorter curves of guide catheters and try to push it up to engage it, that time you have to remember that there is intima in the left main, and if that gets dissection, it generally goes to the circ, because you are pushing up. This happens more often in radial or with EBUs looking up when you're trying to push up like this. Therefore, many people still believe Judkins is the best guide catheter. And many people don't use EBUs still as on today. But if you use, you have to be gentle without pushing it up like this and trying to dissect the left main. XP, same EBU, XP, both. Yeah.
Sir?
Come near, yeah. Thank you.
Okay. So thank you all chairpersons. The chairpersons for the next session, the talk by Dr. Nihar Mehta. So the chairpersons here are Dr. Akshay Mehta, Dr. S.B. Gupta, Dr. Anil Sharma, and the moderators are Dr. Samhita Kulkarni and Dr. Nikhil Nair, if they can come. One very important announcement before we start this. After this session, we have our annual general body meeting. And all the CSI members, please stay and attend. It's a once in a year event and many important things have to be discussed. And there will be no lunch until you attend that meeting.
Should I start? So, after a very engaging session on complications, I am going to give you all a very simple and a very straightforward way to make sure you never get a complication. And that is by not doing an angiography at all. So now we are going to talk about prevention and how to prevent problems like blood pressure and cholesterol so that your patients don't need to get a coronary angio at all. Now, and please don't worry, folks, I'm going to be very brief. And we are basically going to talk about a predict score, which is a score which helps us guide the borderline cases. You know, we all have patients who have crazy lipids or like a high LDL or a high blood pressure, and we know how to treat them. But we are talking about those borderline cases who we are not sure whether they need therapy or not. And sometimes these are the toughest patients to treat. I think every single day in our OPDs, we get one question: do I need a statin? Can I manage without my blood pressure medication? And this sometimes will help us to decipher which patient will actually benefit and which will not. So if you have, this is a very random 60-year-old guy with a blood pressure of 138/83. I don't know how many of us would actually start an antihypertensive for him. And he has a high LDL of 164. Now, what are we going to talk about is counseling this patient for his risk of CVD and how do we have evidence to reduce these risks. So first is why. Why do we need this atherosclerosis prevention? Because even though we try hard, we have a high risk population amongst us who will get coronary events or atherosclerotic events. Now, instead of treating the whole population at blanket, it's better to identify these high-risk people and then treat them. These are not the ones who are very clear-cut, but these are the borderline ones. And why is this? Because in spite of all the efforts we take and all the angioplasties we do, the risk of CVD is still high and it is increasing day by day. Now, a lot of people have risk factors. Now, if you see this is Indian data, ICMR. 1 in 9 Indians have diabetes, 1.5 out of 10 have pre-diabetes. 1 in 4 Indians have high blood pressure. And so if you can, the number of Indians who have multiple of these is also very high. Now, how do we predict whether there's a problem? Many risk scores exist. And I'm sure everyone here is thinking, is this practical? In my OPD, am I going to really use this? So, you know, this is going to be part of our practice in the future, so we might as well accept it. When we get automated and you put in your patient's data, eventually a risk score is going to come up for us. So we should know what are the cutoffs of high, moderate, and low risk. Now, today we're going to talk about the prevent score because that is the score which has been the most recently validated score. We are trying to catch a patient in an early phase of their risk so that they don't get into a clinical cardiovascular disease state. That is before stage 3, even before they get subclinical cardiac disease.
So a lot of articles have been published on this, and there is a lot of validation, like over 7 million people have been studied to validate these scores. And this is the score which is this PREVENT score, where you put in these data points. So it is not just your age and your cholesterol, but this score has many more things, from age, sex, cholesterol, BMI, diabetes, blood pressure, medications for statin lowering, or meaning for statins or antihypertensives. In addition, you can add additional factors like your social index, meaning the kind of society you're coming from, HbA1c, and your urine microalbumin. This can be added to give a very comprehensive score. So all these risk factors, this calculating scores which exist, the highest validation is with the PREVENT score. Now, you have a person with high risk, what do you do? Are you justified just with a risk to treat? And the risk number of cutoff which we should remember is 7.5. Anything below 7.5 is mild risk, but anything above a 7.5 10-year risk of cardiac events needs to have some intervention. Now, these are our BP lowering charts from the Indian and the European guidelines, where they are clearly telling us to treat high blood pressure, dual drugs. But what about that borderline blood pressure, when it is 130 to 140 and between 80 and 90? Do you treat this patient or not? Similarly, a lot of lipid guidelines classify all these risks of high, moderate, and low risk. But a person who comes with 102 LDL, are we going to treat them or not? And we know this early and sustained reduction, but how many 32-year-olds with a 105 LDL are we going to say, "Chow, start a 5 or 10 milligram statin," right? So, because we have several therapies in addition to statins, SGLT2, and our weight loss drugs, MRAs, it's worthwhile defining an individual risk. An additional factor to this will be the calcium score. And based on the calcium score, we can add to our risk assessment. So even a calcium score of 1, not 0, 1 is a problem, where you need to have your LDL below 100. So if you are in doubt, in addition to these scores, the calcium score will add to your decision making. Now in this patient with a BP of 130 by 80 and an LDL of 164, his score was 9.1. So it's above 7.5. He has a 9% risk in the next 10 years to get an event. So if we want to prevent all the complications that we've just shown, start 2 drugs for him, a statin as well as an antihypertensive. It could be a single antihypertensive, but it is important. So the value of this is in these 2 things. We all know now pre-diabetes is a condition which we must treat. Remember, borderline hypertension and statin initiation early is a really, really important thing in our practice. So risk prediction is important to enable therapy. This reduces the atherosclerotic, heart failure, and cardiac disease risks. Keep that score below 7, anything above 7.5%, start treatment early. With that, I'll thank you all for a patient listening, and we'll go over to the next speaker.
Thank you for wonderful talk. Would you start antihypertensive in your patient immediately or wait for repeat BP monitoring?
So sir, once it's now very clear in the guidelines, when it is above 140 by 90, it is lifestyle plus a combination of 2 drugs, low dose combination therapy. Yeah, so if it is 130 and 80 or 138 by 83, if you have a high risk patient with other risk factors, then start a single drug immediately. But suppose you have a 30-year-old with no comorbidities, no other problems, then it's worthwhile giving them a lifestyle chance for 3 months. But over 3 months, they come back with a similar blood pressure, start a single drug.
I will advise this patient to have home BP monitoring for 5 days at least before starting. So what is the house opinion?
Confirming this thing that you have that blood.
So I agree, sir. I think I'm a very strong proponent for home BP monitoring, because white coat hypertension is nearly 20%. So we must make sure we average the home blood pressure for a few days before we label them even borderline hypertensive. But, sorry, sir. Remember, the blood pressure cutoffs at home are different. It's not 140/90, it's 135/85.
Here, whatever you mention is all predict score is for the Western population. Now, in LI, we are going to shortly come out after 2 months, ACVD risk profile, risk rather, LA risk. And that almost 33 variables,
Okay.
When, it is validated versus your PCE and the predict. Now, predict, validation is just 50%, PCE is just about 60. So, Indian population, we need, as you mentioned, within 5 minutes, you can exactly think, yeah. And
So,
our, like same, as you said, CAC, coronary artery calcification, blood pressure, lipid, etc., are very different.
Yeah, I agree, sir. It's the need of the hour. I'll just give you all one piece of trivia before I leave. The predict score is more accurate than the other one, which was the ASCVD score. And now that Americans are using the prevent score, I beg your pardon, the use of statins has gone down by 120 million tablets per year, which means that these scores are now getting more accurate and more focused, but that should not translate to a higher coronary burden. So that only time will tell. So I think the need of the hour is now to get our own data, our own scores, and I hope that we can all integrate this into our practice.
Global lipid guideline few days back compared 4, One is ESC, second is American, third is ILEP, which is the international expert, and then the LA. Today, LA is in the global map.
One more thing, Nihar. One more thing, whether you have the borderline risk or the intermediate risk, after calculating everything, maybe you calcium score, one will have to have a discussion with the patient, because after all, it is not 100%. The risk is not 100%. There is a 10% risk, means also there is a 90% risk of not having anything. So shared decision making is very important. Shared decision making.
I mean, so you have to think of probabilities.
Yes.
And likelihoods.
Yeah.
So once you've got into this higher risk category, now you wait for 10 years and they get a event.
So you have to explain all to them. Yeah.
So Nihar, don't go away. Just one point, so if I'm allowed. So the ASCVD calculator, the earlier calculator, gave only a 10-year risk. And this prevent calculator is giving you a 10-year risk and even a 30-year risk. But if you see both these calculators, both of them don't have LDL cholesterol in the risk categorization. They only give the total cholesterol and the HDL.
Yeah, so they have HDL and total. Anyway, LDL is a derivative number.
So now when we talk about escalating the statin therapy, and this prevent calculator.
Vaibhav. This is because LDL is not used in any of these guidelines, because non-HDL is more sensitive than LDL.
So
because non-HDL includes the remnant cholesterol also.
In the risk calculator, sir, they don't even mention the non-HDL. If you see the calculator,
automatically calculated.
Total cholesterol and HDL.
And they advocate the use of statin once the risk is above 3%. So this 7.5 is also not there. If you see this prevent calculator, once your risk is above 3%, you have to start a moderate intensity statin.
Means that is advisable.
But unfortunately, Sada, we don't have any good Indian data validating the Indian patients.
Or our validation is going to be post hoc. It is not from pre-existing data. But I think
even this BMI should be reduced for Indians.
So I think,
the
sir,
BMI cutoff.
I think we, So I think Nihar with his trivia is it's a good talk, but with his trivia, I think he is scared of Sun Pharma. He's saying statin use reduced by 120 million, or either Rozu or Sapan ne likha hai. So Nihar, I think that is a problem. So one quick word, please. This general body meeting is for all CSI members. It is not just the executive committee meeting. That is already over. So whoever is a Mumbai CSI member, please wait for this meeting. Before that, quickly, Dr. Pagar sir and Dr. Nihar will propose a quick vote of quick summary, and Dr. Amit will propose a vote of thanks. And then please wait.
This is more like a take-home message slide. Complication sessions always are the most popular, as is evident by the rush we are having here. People love to see complications happening with others and say a small prayer, hope it never happens with us. all of us are going to face complications, as was told. We need those nerves of steel. We need to have the skill set, and we need to anticipate these. Along with that, every time each one of us sees a complication, a small plaque ruptures in us. So I think Rosuva's new indication is doing interventions. All of us should be on a statin. So just going through the quick summary of whatever we have seen, just like a one-liner. We started off with Brajesh showing us how an anomalous RCA arose from a ectatic segment, and the value of intracoronary thrombolysis. So people who have not attended or not come before, how value of intracoronary thrombolysis is still very, very important. We need to know the adequate doses, use it whenever you're stuck with a high thrombus burden case. Then we had Dr. Reddy showing us the stents when you undersize, the importance of imaging even in a day-to-day routine cases, which we think by eyeballing we have size the stent correctly, but it can bite us when, especially in these large RCAs, when we thought everything was fine, looked beautiful on an angiogram, but stenting, when you undersize, it can hit you back with repeated stent thrombosis. Then I think we had Amit's case where about a radial pseudoaneurysm. I mean, it can happen in spite of so many cases which we do. It is always better to have friends in the vascular interventional radiologist who can bail us out, use CT scans, and that's the only way we can go ahead and get things out. You want to see? I'll finish it out. Then we had Chirag, Dr. Chirag, who presented a very pertinent topic regarding DCB or DES. And all of us swore that DES still happens to be the GOAT, still the greatest of all times. Stent is where we are going to not make a difference with DCBs, especially in the proximal large vessels. Akbar showed us about perforations. As I said, all of us skip a beat whenever the image shows a perforation, especially if it's a large one. It is very useful to have a strategy, a game plan in mind whenever you're doing any case, because perforations, as he showed, can happen in the routine of routine cases. Ensure that your covered stents are in place. Ensure that it is available. Ensure every day that your technician knows that covered stents are going to be useful whenever you have such situations. I think Dr. Gaurav showed us very exotic, very complicated, very densely calcific cases. It teaches us one point, that whenever you're going to use these devices like a rotablation or an orbital atherectomy, make it a point to know what to do if you get stuck. It should be very clear in your mind. You wish that you will never get stuck, but what to do when you get stuck, that flow chart should be very clear in your mind. Only then you can think quite quickly when you're faced with these situations. Dr. Kirti Punamia's lecture again it was not a bouquet of cases, it was a huge garden of exotic cases, and I mean, there's nothing much. He has talked everything what is there, and he has told us how to go about dealing with these complications. The most pertinent thing is consent forms, which we all tend to neglect. Somebody else takes the consent for most of us. So that is something which we all need to keep in mind, try and have an exhaustive consent and ensure that we ourselves talk to our patients, especially if it's these complex cases. Next was Dr. Saurabh. He showed about hardware being lost, degloving, which is a little rare nowadays, but that only tells us that again you have to be very, very skillful with your snares. Don't depend on an interventional radiologist to come to your rescue. We should know what snares are in our cath lab. We should know how to use these snares. You never know when you're going to need them, and that's why you should be absolutely well versed with them. Shishir, of course, showed what can happen when a guide misguides you, or when a guide can cause a guide-induced left main dissection on an RCA dissection. These are times when you have to really be very quick in your thoughts, very quick in your actions. Only then you're going to save these patients. And I think that's what we thought about today. The complication series was, we tried to include all variety of complications which we see in our day-to-day, and hope it has been an enriching value-added meeting for you. Thank you so much.
Before you go further, as a president of CSI, I'll just take half a minute. My suggestion is two things which he has probably missed out, not because of anything, but what I want to add to this is, if you want to do complex cases, please see that you take an elaborate consent. It should be preferably video recorded so that you are safe. And second thing is, don't attempt those cases unless you have all the material on this thing. You cannot say, no, we are poor, so we don't have this thing. Then you don't do it. Please don't do it because you will be in trouble. So have everything with you, take a proper consent, then you are free to do whatever you want to do. That's my suggestion.
So I think the last thing for today is to give vote of thanks before we break for lunch. Oh, GB. Yeah, it's been a long week for me. A lot of emergencies, so probably I'm a little dazed. So I would at the outset like to thank all the presenters for the wonderful cases that they have showcased today. There's always some reluctance in presenting complications because we always worried that people will judge you, but these are the cases which are maximum learning, and I think we all learned a lot. So I think thank you to all the presenters once again for those wonderful cases today. Special thanks to our panelists and chairpersons for the inputs. We learned a lot from it, and I'm sure that all the new interventional cardiologists here will take a lot of lessons from this, from today's meeting. Special thanks to Dr. Kirti Punamya sir. I think he's not here, but his cases as usual are exotic. He's a great orator, and he's taught us a lot about, of course, consent, but also how to manage complications and how to prevent them in our cath lab. We would like to thank our president, Dr. G.R. Kane, sir, our secretary, Dr. Bhavesh Vajivdar, for always guiding us and for allowing us to kind of, Milind is always there. Milind, he's a coordinator, so I'll thank him in the next sentence. So I think for the guidance and for allowing us to do this complication meet. Of course, my co-coordinators Samir, Milind, and Nihar for all the hard work that they have put in. All the EC members also, because every time there is a chat on the group, everyone comes in with their own suggestions. Cannot forget to thank our sponsors, Sun Pharma, because they've always been there throughout for all the Mumbai CSI meet, and they've always stood by us. Thanks to the audiovisual guys for this lovely. There were hardly any glitches here, and of course, thank you once again for coming for this today's meet. We have a full house, and we hope to see you all again in the next physical meet, which we shall have. So, thank you so much.
So now we are going to have the annual general body meeting of our whole body, and CSI members, all Mumbai CSI and CSI members basically should stay. In case you are not a CSI member, you may have to wait outside for a little while. This meeting is not going to be long, and after the meeting we are going to have lunch. So the meeting will be chaired by our president, Dr. Kane sir, and the co-chair will be Dr. Bhavesh Vajivdar, our general secretary. So I please request them to assume their chairs and start the proceeding.
All right.
Boss,
hello.
Let us try and finish this fast so that we get enough time to have lunch and discuss and all. So please help us to finish this as fast as possible if you can. So I'll ask Bhavesh to start.
Hello. Yeah, good afternoon everyone. And please maintain a little decorum for this, for a short time. This is not going to be long. So we start our annual general meeting for this year, and I would like to thank Dr. Kane for guiding us through this full year for I think a very successful CSI Mumbai Branch year. So we start with our agenda. For the first is apologies. So we have apologies from Dr. Ajit Desai, Dr. Anand Rao, and Dr. Iyer. They have communicated that due to unavoidable circumstances, they won't be attending. The second is condolences for our colleague who left us this year, Dr. Daruwala. We miss him, and I think we should have a minute of silence in his memory. So request everyone to please arise. And Dr. Anil Kumar, sorry. Yeah. So for Dr. Anil Kumar and Dr. Daruwala, a minute silence, please. Thank you. So the next thing on the agenda is to pass the minutes of the last general body meeting. We have already sent this on the WhatsApp group. I have circulated it. Somebody wants a physical copy, we have it here. So can somebody propose? And Dr. Sadanand Shetty is proposing it, and Dr. Vaibhav Dedia is seconding it. Yeah.
Accepted.
Accepted, yeah.
Accepted, okay. Any discussions from the last meetings?
I don't think so. Yeah. I don't think so. No? Anyway, no. Okay.
Okay. So we can now discuss, present the activities which we have done in the last year. We have had a very elaborate and extensive list of meetings which we have had, starting with the AGM which was done on 8th of February 2025 by the previous body, and then we started our own activities, and the first program was the EC online meeting on 13th February, and then we had the first online academic program on 28th March 2025, which was on clinical infectious disease in association with the SIT Society, followed by 11th April, and again an online academic program on hypertrophic cardiomyopathy, which Dr. Dargad had arranged. Then we had a physical meeting on 11th of May 2025, complex situations, acute myocardial infarction. It was a physical meeting here at the Geo Convention Center. Then followed by an EC meeting on the same day, and one more EC meeting on 24th of June. Then there were some good journal clubs which we had, and the first online journal club was coordinated by Nihar and Vaibhav, and this was on 18th of July 2025, when we talked of newer drugs like finerenone, tirzepatide and obicetrapib. Then there was an online PG track meeting on 24th September on aortoarthritis. Then a physical meeting that was by Professor Dr. Jairanganath of the Jayadeva Institute. Then we had a physical meeting on 5th of October 2025 on OCT and orbital atherectomy. Again, we had guest speakers Ronnie Matthew and Girish Navsundi, and Amit Sanghvi had organized it. And we had an EC meeting on the same day. And then the next journal club came on 17th of October on cardiogenic shock. And Vaibhav had done it with Nihar. And the speakers were from various hospitals. I think the moderators were Dr. Pelajani, Dr. Abhi Mehta, and Dr. Yunus Loya, and some many panelists. Then there was again an emergency EC meeting to discuss about the registration for Darpan and all, which had become necessary at that time. We will go a little fast. Okay. Then an online PG track program on 19th of November on constriction versus restriction by Dayasagar Rao, done by Snehal Kulkarni, Milind Phadke and Dheeraj Kumar. And again a webinar on cardiac amyloidosis by Dr. Dargad and Dr. Milind. And that was on 20th December, 27th February this year. Journal Club on Coronary Artery Disease, coordinated by Vaibhav and Nihar. And 11th March, PG track grand rounds by Dr. Anita Saxena on rheumatic heart disease. And then again an EC meeting. And our last physical meeting was on 26th of April 2026 on advances in cardiac therapeutics. Again, Amit and Milind had done it with a lot of speakers, and it was a good success. And now this today. So we have a lot of
attendance. In fact, online meetings have more attendance than the physical meetings.
I request everyone to sign the attendance form, please, which is being circulated so that we...
So we have had an excellent academic program, and we hope to continue that. So next item.
Next item is a brief about the accounts. Dr. Dargad will just tell us a little brief.
Presently, on the account actually up to that has taken circulate. The 31st March we had 29 lakhs actually with our account, and on June 31st we got 31 lakh 19,000 is the total amount. Presently with our account in the HDFC Bank actually. That is the corpus we have. And we're supposed to get a big chunk from the Praful Kerkar, which is going to now Central CSI, and 1 crore 9 lakh something is actually, which is probably hopefully to get back from CSI, then only our corpus will work. Presently we have 31 lakh, and somebody wants a copy, I have the registered copy. This year we got actually 1 lakh from the Crystal Mayor and some from Sir Partners ahead. 29 lakhs for the March end, and we are going to file the returns now. We have some profit of around 1.5 lakhs, something we have to pay tax on that. Income tax as per the charter account. Any suggestion? So I think this is the Dani, who is the Mr. Dani, is still the charter accountant. I'm going to file the returns, and this is the present situation of our financial status.
Okay. So
then, I think anybody can convince Praful to send it back to us. Can be great.
Can we?
We have to. What says?
No, we are coming to that later, sir. We are coming to that. So for this presentation of accounts, do we accept what?
Yeah, okay.
Okay, no, somebody else has to propose and second. Okay, Dr. V.T. Shah and Dr. Dhiren Shah. Okay. Now the next very important and sensitive topic, transfer of the balance funds of CSI 2018. And this is an ongoing process. I think, sir, you would be the best person to answer.
So, see, the thing was, because of several factors which always happen after conference, the accounts were not closed. But now the latest thing is Praful has closed all the accounts. And there were some issues of the organizing committee at that time, because there was no CSI Mumbai chapter, branch, and so all those things are getting sorted out. And 1 crore 9 lakhs is the balance. So they are in the process of sending it to Central CSI. So we are going to write a letter today to Central CSI. Instead of transferring it there and transferring it to us, they may as well ask the Kirkar, Dr. Satyavan Sharma committee to transfer it directly to the Mumbai CSI branch, which is existing right now. So let us see. Anyway, either it will come directly or it will come via that. We are hopeful that Central CSI will honor that and send us all the money, because that is all our money. And they have already transferred 40 lakhs before also. So we expect that this will also come. Yeah. This 29 lakhs which we have now is from that corpus of 40 lakhs which is come. Okay? Yeah. 1 CR 9 lakhs, hopefully. Yeah. That's what is our this thing. Yeah.
Okay. So.
Okay. So thank you so much for that.
Now, is anybody have to talk about some future activities?
No. Yeah. Anybody? Any suggestions how we can make these programs anything better, or everybody is happy with what is going on?
After you get 1 crore, we will discuss that.
Okay.
Done. Yeah. That's the right.
So we are actually, to be very frank with you, we are thinking of doing some research activities for CSI, but it requires funds. So so we can discuss that. Plan. Definitely. Thank you so much for that suggestion. Yeah, right. We agree with that fully. Yeah.
The last agenda is, if anybody has any other business, we can ask the chair, and then we can. Yes, sir.
You said the current committee has been very active, and you should put it on record that they have been proactive in improving the function of CSI.
Thank you very much.
The academic standards.
Put it on record.
Okay.
Academic standards.
Yeah,
that is very important.
Most important improvement in academic standards.
Yes, good meetings and good attendance.
Yes.
Thank you for that kind comment. And if there is, yeah.
So you would recollect in our last AGM, we modified our constitution slightly so as to regularize our election schedule. Now the thing is ki every time a new body takes charge, initially it used to be January, now because of last year's slightly delayed election, it has been February, March. Now the problem is, for smooth functioning, it is best that one body handles one financial year and gives it to the other body at the end of the financial year. So that what happens is ki a new body can start accounts on a fresh slate on a new financial year. So it is proposed that we extend the term of this present body to 31st March. The elections will take place as scheduled, if there are elections in October, November, we will announce the full schedule. So instead of February, we extend the term of this body to 31st March, so that the new incoming body can take charge on 1st April, so that they can completely take over.
All agreed.
So, no, this is a slight change.
How does it matter?
So, for example, now I will tell you. So the thing is, ki sir, accounts are handled by the previous body, and the account statement, the passwords, everything is with the previous secretary and the treasurer. Now, when the secretary, treasurer, and this one change, one person should be responsible for the accounts of one financial year.
Because the accounts are being submitted to the income tax in September. So
that's okay, but they are for the previous year.
I don't think that the accounts matter.
But financial year ends.
No, but the financial year ends on 31st March. I put this to a vote, please. What do people think?
I think we want to change that. It's our proposal.
You give it, it's of the previous year.
It's of the previous year.
But finance starts
Normally, CSI headquarters has got the elections in August, September. So I think if we can align with those election timing, that previously it was happening accordingly. So we can align.
No, Dr. Gupta, I don't think that is important for us. Our important for us is how smoothly we can function. The best smooth functioning can happen if we change at the... I have had problems like this before, so this is my suggestion as president, that we should take over from 1st of April, if everybody agrees to that. Okay.
We can vote.
Okay. Yeah, okay. So by voice.
So can we accept this by voice vote, please? Because this is a change in the bylaws of the constitution, so it is so passed here.
Yes.
which is easy and smooth. That's
Yeah.
we don't want headache.
Yes.
Yeah. It's an academic body.
Okay. Any other business? Okay. So, yeah, if there is no further business to be conducted, then we will make a concluding remarks by the president and then adjourn the meeting.
So, Tula bola hai? Okay. So I want to thank each and everyone who is present here for participating in such large numbers, and we expect your cooperation and help in conducting these programs. Thank you so much for coming. Please join us for lunch.
With Milin permission, we'll have lunch. With your permission, we'll have lunch.
तेरे को एक महीना एक्स्ट्रा मिला है, एक चाय पिलाना पड़ेगा।